Hello, good afternoon, everyone, and welcome to Organon's Pharmacist Academy first session. My name is Hanan Al-Mansouri. I'm the Brand and Customer Manager for Organon in Kuwait, Bahrain, and Qatar. And it gives me a great pleasure to welcome you all and thank you for joining our academy. Organon Pharmacist Academy is a full educational program, and it is designed to empower pharmacists in KBQ to deliver excellence in patient care everywhere and every day. It is done in collaboration with Kuwait Pharmaceutical Association in Kuwait, as we both believe in the critical role that the pharmacists play in the patient journey. The program is CME accredited, and it will be certified from Dublin Institute of Business. Participants will receive the CME points at the end of each session. However, participants will need to complete the full program in order to receive the certificate of completion from Dublin Institute of Business by the end of the program in October. So the program is 3 sessions. We will start today with our first session, and we will have other consecutive sessions in September and October, and we will be sending you reminders as well. So without any further ado, I would like to start our first session today. And please, if you have any questions, please just type them on the chat and we will read them to the speakers after they are done with their presentation. So now please allow me to introduce our first speaker for today, Dr. Anas Hamad. Dr. Anas is currently the Director of Pharmacy Department at Qatar's National Center of Care and Research, and he is the head of Medication Safety and Quality Center at the Pharmacy Executive Office at Hamad Medical Corporation. He holds an adjunct position as an Assistant Professor of Clinical Pharmacy and Practice at Qatar University, and he is chairing the Standing Committee of Medication Service at Qatar Red Crescent Society. In addition, Dr. Anas is an active researcher with many publications, and he is in the editorial board member of the International Journal of Clinical Pharmacy. Please join me to welcome Dr. Anas. And Dr. Anas, this floor is yours.
Okay, thank you very much, Ms. Hanan, for the kind introduction. Thanks to Organon for hosting this meeting, and to the colleagues in Kuwait Pharmacists Association for their endorsement. So today we'll be speaking about the evolving role of pharmacists in value-based healthcare. And as you know, the term value-based healthcare maybe is being used a lot in the last couple of years, and I'm sure every one of you have heard of it. And we pharmacists have a huge role to play in value-based healthcare. So today we'll just focus on different aspects that we can do in our daily practice, in our daily work, either in the hospital or in the community pharmacy, that can contribute to value-based healthcare. So value-based healthcare is the healthcare, of course, that we all provide, but centered around value. So keeping value in mind, and value is in everything. So value is in being efficient in utilizing the existing resources. Either these resources are monetary, like financial resources, or even if these resources are human resources, or equipment that we have, or data that we have, etc., etc. So it's all about keeping value and efficiency in mind. Even our procedures, our processes, to make it more easy, to make it more simple, wherever possible. So the ultimate goal of this is to have the patient-centered care that we always talk about. So patient-centered care is keeping patient in the middle, focusing on their outcomes, clinical outcomes of the patients, but at the same time with a high quality of care, and also in the most efficient way. So we spend our resources in an efficient and wise manner. So the triple value healthcare is just very broadly. So there is three types of value generally. So the first one is called allocative value. By that we mean how the resources or the assets that are available, the money that is available, distributed to different subgroups. Let's say in the beginning of the year, this cardiology will request this amount of money, cancer will request this amount of money, specialty primary care will request this amount of money, and you have this fixed budget, let's say 1 million riyal or 1 million dinar. How are you going to allocate this amount? So you have to keep value in mind, like by giving this amount of money to this department or to this specialty, we are producing more health. And by that we mean we're getting more benefit from this expenditure as a return on investment. And of course, it's not money that we're getting back, but we're getting more health, better control of the disease. This disease we have a bigger issue with, for example, in our country. So we want to focus more. But we know that there is a very effective treatment that will make big difference for patients. So we invest more there. So how you allocate the budget that you have based on different subgroups or subpopulations. And then the technical value is how well these resources are used. So yes, you have the budget now. How are you using this budget? How well and how efficient are you using this budget for the population that you are taking care of? So this is the technical value. And the third one is the personalized value. So this is the one that is related to every single individual or every single patient. How are they benefiting from this budget that was allocated for this specialty? How well are they responding? They're getting better, for example, adhere to their medications. They're getting a medication that is less toxic than the other one, etc., etc. So this is the personalized value. Of course, as we are pharmacists, we have to focus more on medications. So during this presentation, I'll be focusing more on the value related to medications and our role again as pharmacists in that. So this article was recently published by Forbes, and as we know, Forbes is a very famous website and organization focusing on economics in general. But they published this nice article about the pharmacy's role in the era of value-based care, which we are living at the moment. So I'm just quoting here. So in the dynamic landscape of healthcare, the concept of value-based care has emerged as a transformative force, shifting the focus from quantity to quality. And this is very important. So our focus now always, when we take care of patients, is not only about the volume, but it's also about the quality that we are generating because of this decision that we take to have this drug or because of this intervention that we're doing. So value-based care emphasizes the delivery of healthcare services that yield, so achieve, positive patient outcomes while reducing costs. And this is the hard equation, يعني المعادلة الصعبة. We want to have more patient positive outcomes at the same time at the best or the most efficient way possible. So with the least costs possible. I don't want to stop investing money. Yes, I want to invest money, but I want to generate out of this money the maximum value in patient outcomes possible. So this is the equation that we want to achieve. It's not easy, but it's possible. So this is becoming very, there's big momentum about it. So it's very trendy. Everyone is talking about it, sometimes more than doing it. And so we need to focus on doing it also, not only talk about it. So the role of pharmacists is becoming more and more important. With our expertise as pharmacists, our accessibility, pharmacists are everywhere. Anyone would have at least a community pharmacy near their home. So pharmacists are the most accessible healthcare providers. We always say that. And our focus on patient-centered care, pharmacy has the potential to revolutionize the way in which healthcare is being delivered. And this, for example, in COVID days, this was a huge example of success. Many, many countries all over the world, including countries in the region, like Saudi Arabia, for example, did a great job in community pharmacy utilization, in immunization, in doing COVID tests, etc. So that was a huge success story of utilizing community pharmacy for value-based healthcare. And this can be done, of course, in different aspects, but this is just an example, the COVID. So we always has to have clear outcomes and goals. And this is depending on where we want to achieve. So we always say and believe that our task as pharmacists is to take care of patients. And so we are focusing on different aspects regarding the continuity of care, about the reconciliation of medications. And this is not only pharmacists, but it's in coordination with physicians and others. And this is either upon admission or discharge. The chronic disease management, which is a huge focus for pharmacists, and most of the pharmacists' clinics and interventions are related to chronic diseases, where many countries like the UK, for example, now diabetes and hypertension are managed by pharmacy to a very big extent, even in the chronic phase, even more than physicians, actually, in the UK, for example. We want to focus on the total cost of care. So if we invest in medications, we save elsewhere. So yes, I'm giving $1 million for this new medication, but I'm expecting to save $2 million in, for example, cost of admissions to the hospitals or ICU or length of stay in the hospital. So that we look at the total cost of care, not only the medication cost. Adherence is one of our major roles, and we will talk more about that. Appropriateness of medications, and of course, outcomes. We always have to look at outcomes. What are the outcomes of our work? We talked about immunizations and preventive services, and this is even include tobacco cessation or smoking cessation services that are provided by pharmacy, as well as other services in terms of preventive services. Of course, our role in avoiding emergency room or hospitalization is very important. And many studies have shown that pharmacist interventions can avoid or lead to avoiding patient admission to the hospital, where their drug therapy is being controlled well. This will leading to their disease control in a better way. So it will avoid their hospitalization or readmission to the hospital. We have always to keep an eye on global trends, what's going on in the world, in our industry, in pharmaceutical industry in general. And this is just an example, focusing on the community pharmacy and primary care pharmacy in general, where they found that there are 5 major trends in the US that are being ongoing at the moment. And but I think it applies to all sectors of pharmacy, not only community pharmacy, which is moving from volume to value, as we mentioned. So it's moving from what is called fee for service to pay for performance. And by that we mean we're just stopping just paying for, well, for example, this service is costing $10. خلاص, I'm paying $10 of the service or of the drug or of the product, regardless if I will benefit from it or not. Now, with the new drugs that are more expensive, high-cost drugs like rare diseases or cancer drugs, etc., where there is still some uncertainty in the outcomes, we are not sure if the patient will respond or not. That we are moving to a model called pay for performance. By that we mean I will pay if the drug works for my patient. I will not pay if the drug does not work for my patients. Of course, it doesn't work in everything, but in many areas where there is what is called uncertainty, we are not sure about the outcome. This is becoming a more trendy approach of payment or of procurement. It's called pay for performance or value-based agreements, some people call it. And the major trends that are under this umbrella include transformation. And I think all of our region, GCC region, is moving towards transformation in the healthcare, where we are moving to privatization, private insurance, mandatory insurance schemes. And I know this is being done everywhere in the Gulf, and all countries are moving towards having mandatory insurance schemes for expats, but also for locals as well. So this is becoming important to keep aware of what's going, because it will impact our way of working. Data is, we will talk about that, is essential. And pharmacy work is all about data now. And we have a huge amount of data that we are still not utilizing up to the maximum that is possible. And again, outcomes should be always in mind. So we're not only focusing about buying the drug and selling the drug, we're focusing about what are the outcomes achieved from this procurement. And that's why we're talking that it's performance-based procurements. It should be focusing on the outcomes. And of course, alignment is needed, because alignment is about alignment with others, alignment with physicians, with nurses, with laboratory, with with finance, with insurance. So it's a multi-stakeholder job, and everyone should be engaged in their specialty and reaching to a consensus of the best way to go forward in anything we do. So collaboration is key and should be always multidisciplinary approach is the best way to go forward. So what is the role of us pharmacists in health economics? Of course, as you know, medications are getting more and more expensive. I think you all see the new medications in different areas with precision medicine, with rare diseases, with oncology, biologics, all biologics in rheumatology, immunology, dermatology are coming with a very, very high cost. I think we all see that on our daily practice. So there is a need to have better pharmacoeconomic evaluation. We need to assess these medications, not only against their cost only, but against the full picture, as we said. What value would this drug add to me in terms of other costs? Would it save elsewhere? Would it improve elsewhere? Would it really improve? Of course, always we are ready to pay more, but again, for what's worth it. So is this a new drug or a new medication, high cost medication, adding a value that is worth the extra money that I'm paying for it? مثلا, is it extending the patient lives? والأعمار بيد الله طبعا. To the extent that I am happy to pay مثلا 3 times more for this drug, well, because the cancer patient is living 5 years longer because of this medication, مثلا. This is done through, of course, equations, etc. But this is the concept. This economic evaluation is needed to identify, measure, and compare the cost of different therapies, drug therapies, or even services that we do, and what is the significance that this, as I mentioned, these new technologies or new drugs will have on the total healthcare budget and on the patients and the patient outcomes. So pharmacists can have a major influence on healthcare decision making, again, regarding better allocation. So the resources are not, infinite. So they are finite. So we have limited resources, even if it's good budget, but still it's limited. It's not unlimited. And so we have this number at the beginning of the year. We have to manage within this number. So we have to be smart in how to utilize the resources that we have. And so doing a pharmacoeconomical evaluation is really essential to have the maximum outcome out of our resources. So with our unique knowledge of medications, as we always call ourselves, we are the medication experts, pharmacists. So we are really central in decreasing the healthcare expenditure through cost-saving initiatives regarding medications and also cost avoidance, where we will go through some examples later where pharmacist interventions are actually avoiding many costs, many unnecessary costs, stopping unnecessary medication, again, avoiding, for example, admissions or readmissions, as we mentioned before. So I'll go through some specific areas where pharmacy and pharmacists can play a significant role. So the first one is the one that we always do, medication therapy management. And so medication therapy management is, of course, again, as we are the medication experts, we interact with medications, we educate about medications, we review medication orders, we check their appropriateness, their indication, their interactions with food and with other drugs, and the side effects. We provide MTM services, so we work with patients, we educate patients, and even we educate other healthcare providers, doctors, nurses, and other about medications, about side effects, about adherence and importance of adherence, and understanding the patient aspect and perception about that, so we can improve the outcomes of this medication. Because sometimes patients would lose one line of treatment because, for example, it was causing them a small side effect, but they didn't tell us about it. So if we don't sit with them and ask them, we will never know. So they will just stop the medication and we will go to another treatment. So they lost one line of therapy for actually something that could have been managed with giving another symptomatic treatment or giving dose reduction. But haram to lose the whole line of treatment, because sometimes the lines of treatment are limited. So we have to have a comprehensive approach, not only to enhance the patient safety, but also to have better health outcomes for the patients and again, having an impact on the utilization of healthcare resources. Chronic diseases management, as I mentioned, is one of our core aspects and our core services that pharmacists can have to play a great role in. And this is by providing like diabetes, hypertension, hyperlipidemia, asthma. Pharmacists can play a huge role in patient education, counseling, ongoing support. And this even can be done at the community pharmacy level. And I'm sure all of you have seen patients or are seeing patients who are coming back for their medications and providing them with many of these services already. So by helping those patients understand their medications better, develop some healthy habits about the disease, about healthy food, about exercise, etc., pharmacists will empower those patients to take control of their medicines and their condition, and so prevent complications from these diseases. So it will help them to adhere and continue on these medications. It will also reflect on the healthcare resource utilization. So again, utilization of the hospitals, of the clinics, clinic visits, admission to hospital, emergency visits will be less when we control the patient and their disease better. This study in the US have shown that 86% of healthcare costs in the United States is related to chronic diseases. So chronic diseases, yes, we do have the rare diseases. Yes, we do have the cancer. And these are their individual treatment is very, very high. It's like for example, one cancer treatment, you can treat 100 diabetes patients sometimes. Yes, that's right. But when the number of cases is much less. So when you look at the total picture, still the major burden of healthcare is related to chronic diseases. And this is not only medications, the total cost related to admissions and care and visits, because these also diseases come with aging, as we know, with time. Most of us will have diabetes, will have hypertension, will have hyperlipidemia. So, and if it's a country like the US, where there is a huge population above 65, this is a major cost to their healthcare system. Another thing that we always have a big role in as well is the preventive care, as I mentioned before, and immunization. I talked about the example in COVID, but also many countries like the US, the UK, and I believe some countries in our region as well, including Saudi Arabia, are doing basic immunization services in the pharmacy, in the community pharmacy. And this is very helpful, even more in the areas like the rural areas or the suburban areas away from the city, where this can be of a huge value to parents or to families, or even if you go to have vaccination, to go to Hajj or to go to Africa for a visit or whatever. Some countries in Africa, of course. So it's very important. Preventive services, again, related to, for example, healthy diet, having exercise, smoking cessation. These are all considered preventive services. So you are preventing, for example, a high blood pressure patient who are taking one medication for now, ACE inhibitor, for example, to have the need to take 2 or 3 medications. Or a patient who's just taking metformin, for example, if with the good control with exercise, with diet, they would just stay on metformin. They will stay as pre-diabetic as long as possible without the need to go for a more aggressive anti-diabetic agents. So preventive, so this is preventive, lifestyle related, and immunization, as we talked about. So this is a huge role for us pharmacists that can be done in the outpatient pharmacy or in the primary care center pharmacy or community pharmacy with very effective approach as well. And that is even comparable to physicians, by the way. And we have seen many studies that compared between the chronic and preventive services management between pharmacists and physicians, and they were equal. They were non-inferior, by the way. Of course, at the end, this would reflect on the healthcare expenditure and the efficient spending, where again, we will manage to, as I mentioned, to prevent further progression of the disease, which will cost more money, either by giving more medications or by leading patients to go to hospital, etc. So indirectly, it's saving money and healthcare resources as well. The fourth point is collaboration and coordination, which is very, very important. We are not alone. We're working in a healthcare system. We need to keep collaborating with our colleagues, especially physicians and nurses, to optimize patient care. We are engaged with others in medication reconciliation, in medication therapy review. At the end of the day, even if you found any issue, you would need to talk to the physician, ask them to correct the dose, to adjust the therapy, to stop, etc. So you will call the nurse, please don't administer this until we check that or check this. So we cannot do it alone. So it's always related to collaboration and coordination, and especially in hospitals where the what we call it, the transitions of care. So when patients are moving from inpatient to outpatient or from emergency to inpatient, these transitions are always a prone area for errors, and there is always higher risk in this transition. So communication and cooperation between different healthcare providers is very, very important in this stage. So this would always lead to better outcomes, and again will align with the principle of value-based care, because we're keeping patient in the center of what we do, and it will lead to avoiding unnecessary, for example, mistakes that will cost us much, much more, or will cause the patient admission to ICU or whatever. And we have seen all, I think, cases where poor communication between healthcare providers has led to, unfortunately, patient harm. There are many, many cases of that. So good coordination and communication will always minimize this risk. Data, and I think in our era now, we're all using somehow an electronic system, either if it's a full electronic health records in the hospital, or even our local pharmacy electronic system. I think most of us would have that. And this is actually a huge source of data. We have lots of data. I can tell you about my hospital. We have a huge, huge amount of data that still are underutilized. We are not using the data as to the maximum benefit that we can have out of it. So data analytics is very, very helpful to track patient outcomes, to track medication adherence, to track medication related to patterns of utilization. And this will help significantly to having proper, when you do this proper analysis to the data that you have, you can understand what's going on with the patient and with the healthcare system or the hospital level in terms of this medication or this disease area. So for example, you can take let's say one cancer type, and you can see all these drugs that are used for this, for example, cancer. In your hospital, you can generate data for all the drugs that have been used for this specific cancer. What are the drugs? What were the outcomes of this drug? Which patients are benefiting? Of course, you have the clinical trials, you have the guidelines, that's right. But always it's good to have your what we call real world data. So real world evidence from your hospital on your patients, because we know always drugs and response to drugs is different between different patients. So you can understand this by generating real world evidence, and this can be done by data and analyzing data. Also, you can use data for quality improvement. So for example, you can check as simple as the waiting time. Waiting time for our patients in the outpatient pharmacy is, we are aiming for 20 minutes, but when we analyze the data from our last month, we found that it was 40 minutes. So we have an issue. So we can know that first, that we have an issue from the data. And then we can start to working on the some solutions and test these solutions. Again, using the data, we analyze later if this new solution have improved the case or not. Yes, you can, for example, one or two patients, you can see, you look at your watch and see what was the waiting time. But if you want to look at thousands of patients, that's not possible. So you need data and data analytics. And this can be applied to anything you can think of, for example. So even working with others like insurance or like big healthcare systems, they can work with pharmacy and pharmacists to interpret this data and improve patient utilization, medication utilization, in order, again, to improve quality of service and the value that we are providing for our patients. Adherence is a major issue, and unfortunately, as they always say, medications won't work in patients who don't take them. So sometimes we think that we've done the full job after we dispense the medication to the patient. خلاص, we checked it, we double checked the medication, no errors, indication is right, dose is right, dosage form is right, patient took the correct quantity, but actually the patient will not take the medication. And this is a very, very common issue. Many studies have shown that, first of all, we have a huge wastage of medications because of non-adherence. Patients are not taking the medication. And also, patients' condition will not improve, and so they will come back to us in a worse scenario or worst case. So this is just some examples. Within 6 months of initiating treatment, most patients are taking less medication than prescribed or have stopped completely without sometimes, or many cases, without telling their healthcare providers, without telling their physician or even their pharmacy. Too often, the result is hospital admission and emergency department visits. At the end, poor adherence cost the US healthcare system as much as 290 billion. That's a huge number to believe, but these are valid publications. This data is not from myself, so it's all published, validated data. Around $300 billion is the cost of non-adherence. And the cost of non-adherence is not only the wastage of the medication, it's the admissions and the hospitalizations that happened because of non-adherence. So if the patients took their medications, this would not happen. So this is a huge amount of money. And of course, for patients, it's a huge deterioration of health that could have been avoided if patients took their medications. And طبعا it's easy to say why didn't they take their medication, as simple as that. And here comes our role as pharmacists, to meet the patient, to understand why didn't they take their medication and try to work on this. Is it because it's expensive? They couldn't afford? Is it because it's toxic? It's causing them side effects that they didn't report? Is it because, for example, it says, for example, you have to take it 3 times, you cannot stop, and the patient in Ramadan wants to fast, so he stopped without telling you because he wants to fast? This is all happening. So it shows that pharmacists are in a position to monitor patients and advise patients how to improve medication adherence. And some data shows that this can be improved by 30%. I believe even more, but the data says 30% by pharmacists. The impact will have a huge impact on everything, including the 30-day hospital readmissions. So the patients, when they are discharged from the hospital and they take the discharge medications, the rate by which they will be readmitted again to the hospital within 30 days, so this is called 30-day hospital readmission, will be significantly reduced by pharmacist interventions, and also the visits to the emergency department. So this data also from the US shows that adherence issue by which 25% of patients have never picked up their new prescriptions from the pharmacy. So out of every 4 patients, 1 will not ever come to the pharmacy to pick their medications. So they will just leave and go home, and that's it. That's a huge burden, of course, and a huge problem. This data published in BMJ Open have shown that it's about the economic impact of medication non-adherence, and they focused on different disease groups. So they just shown that the annual disease-specific economic cost of non-adherence per person, per 1 patient, can range between $1,000 to $44,000. And again, this is because of the drug that was not dispensed or the non-adhered to, and the disease. And some diseases, if you stop the medication, yes, it's a problem, but manageable. Some diseases, it can cause a heart attack, or it can cause, cancer, for example, progression. So this is a huge cost. And so the all causes non-adherence is between $5,000 to $52,000. That's a huge amount of money per 1 patient. And then they looked at the different indicators that led to that. And as you can see, the number 1 is pharmacy costs. So sometimes patients cannot afford, even if they are covered by their insurance, but they need to pay 10%, 20%. Sometimes patients cannot afford this, so they will not take the medication at all. And other costs as well, of course. They linked this to different indications. And as you can see, they adjusted this for different manners. So osteoporosis, for example, and gastrointestinal problems had a very high cost of non-adherence. And in the unadjusted one, cancer was the highest. So these diseases are associated, unfortunately, with a high, the non-adherence of, related to these medications of these diseases is leading to a high cost, unfortunately. This publication was by the CDC. CDC, we all were hearing about it a lot in the COVID days, the Center for Disease Control in the US, and it focused on cardiovascular diseases. So it focused on the pharmacy-based interventions to improve adherence. And they dig deeper in that. It's a new publication, roughly 1 year ago, almost. And they showed that pharmacists can do proper assessment for cardiovascular patients by doing interviews with patients, either virtual or face-to-face interviews, to understand and to identify the adherence barriers for those patients. And then they can develop a tailored plan for those patients. After you sit with the patient, understand their concern, understand their reasons for not utilizing the drug. If it's cost, you can link them with for example, patient support program. If it's toxicity, you can look for dose adjustment or for another drug for them that suits with better. For example, if they're taking ACE and they're coughing, as simple as that, you will switch to ARB, as simple as that. Or if the drug is working very good in a cancer patient, but they have an issue with one side effect, diarrhea, for example, you give a drug for diarrhea so they can continue the drug on the cancer drug. So sometimes it's as simple as that, but you need to sit with the patient to understand what's going on. So this tailored guidance includes, again, medication counseling, and sometimes even it needs some psychological support, motivational support. It can be it can be more than one times. You can help the patient with some tools like, reminders, some these pill boxes divided for the patients of the, days of the week, as simple as that, medication cards, mobile applications. There are different things that you can help the patient with, but this makes a big difference for patients. So we want, again, to maximize efficiency. So focusing again on adherence, this data from WHO shows that if we remove ineffective and wasteful interventions in Europe, this is what it was in Europe, in healthcare, if we remove the redundant, some bureaucratic processes, as well as the wasteful interventions that are not unnecessary and waste resources, waste money, waste drugs sometimes, we can save up to 20% of healthcare expenditure. And this is a huge amount. You're talking billions. So this one, for example, this one of the results, one impact of inefficiency is due to the lack of treatment adherence. Again, the non-respect of adherence in Europe is costing the European healthcare systems around 125 billion euro. In the US, we said 290. Here in Europe, 125 billion euros. So these are crazy numbers. And this is just because of poor adherence. So improving adherence is great for patient care and patient clinical outcomes, and also for cost saving and cost containment. And again, some examples they gave include telehealth, screening, early detection of different diseases, including cancer, for example, and proper waste discarding and waste reduction. Even sometimes waste reduction by utilizing, I think I will speak about that, utilizing some, for example, you have one, I have it here. So these are some examples from my hospital, from the National Center for Cancer Care and Research in Qatar, where, for example, we have some drugs where the dose of the drug is based on the patient weight or the patient body surface area. So you give, let's say the vial is 100 milligrams, the patient would need 80. So this 20 will be discarded. Usually it has a stability of 24 hours. So we will just discard it. This 20% sometimes cost, 2,000, 3,000, 4,000 riyals because the vial is like 20,000. So we discard it. So we came with this initiative, and we are not the first one, and this has been also done elsewhere in the world before. So we try to bring 3 patients, for example, that are taking the same medication, in the same day, or we look into the specific drug details where it showed if you, for example, put this drug in the fridge, it can be stable for 48 hours instead of 6 hours. So we will have another patient. So the idea is that we will use these remains, we call them remains and vials, for other patients rather than discarding them. And by that, we saved and this I think 2022, we saved around 1.25 million Qatari riyals, like Saudi riyals, in 1 year only. So that was, for example, an example of efficiency. Dose rounding, I think you all know dose rounding, where we yeah, I have examples here. Yes. So vial sharing, I'll be talking about dose rounding also. So this is the idea where you bring sometimes like the one in the middle here, where you bring an excess from one vial, an excess from another vial, sometimes 3 vials, and you give it for one patient. So you save 1 vial for every 3 patients treated. And this is a huge saving rather than discarding it. So this practice for us in the INT'L, our hospital, we call it the abbreviation INT'L. So we saved a lot of money. So we've done this for 63 IV medications, different types of medications, and for 24 cancer chemotherapy medications, or targeted therapies, monoclonal antibodies, etc. And by that simple exercise, we have saved, as I told you, 1.25 million Qatari riyals per 1 year. Dose rounding, we put for ourselves a limit if the dose prescribed by the physician is up to 10% higher than the size limit. Let's say the dose was 1,000. When you calculated the dose based on the weight or the body surface area is 1,060 or 1,070 milligrams, and my vial is 1 gram. 1,000 milligrams. So I will just use my vial, and that's it. So I will round it down. This is called dose rounding, and dose rounding is acceptable by many studies that it will not impact up to 10%. It will not impact efficacy or patient outcomes or patient response. But it will, because you will use in some drugs that you cannot do the previous move that we talked about, vial sharing, you will lose 90% of the vial, which is haram, as we say. So we've been doing this now for 10 years, maybe, in our hospital. And this data from 2022, we've done this in 11 drugs where this is feasible. Of course, this is not feasible in all drugs. It saves us 400,000 riyals in 1 year only. And this had no impact whatsoever on patient safety or efficacy of the medications. Another thing that we can do as pharmacists that would, again, improve value and value healthcare is non-formulary management. I think all of us would have in our hospitals a non-formulary, or some people call it patient-specific order, where we request a drug that is not available in our formulary for a specific patient. We created a committee in our hospital for that meet every week, like half an hour, just to review the drugs submitted for patients on this week. We don't want to make it monthly because patients are waiting, so we need to act fast. So every Sunday morning we meet and we decide. It includes physicians and pharmacists. All of them are senior decision makers. And we decide. So in many cases, the doctor wants to try a new medication, for example, but we have a good alternative in the formulary. Because as you know, requesting a drug from abroad, it's much more expensive. First, it might need 1 to 2 months to arrive to the country. And we have an alternative in the formulary that is available, as good as, or a little less, but still it's available, free of charge or semi-free of charge for the patient with very small cost, and they can start on it instantly. So we review always, and we accept or reject. Of course, in many cases, still, our rejection rate is 30% roughly, so 70% go through. But it's just making sure that the requested medication is really needed and we don't have any alternative, and it's meeting the international guidelines and recommendations. So we still accept 70%. But just because of these 30% in 2022, again, it led to the avoidance. This is what we call cost saving, but it's cost avoidance. And we didn't order those medications. We used something else available. We already bought. It's available on our shelf. More than 5 million Qatari riyals in 1 year. And this is around 24% additional costs that were going to be spent if we don't have this committee. because before we didn't have it. We just established it in this year, 2022. Also, sometimes, as you know, in some, maybe in cancer, this is more, but sometimes, unfortunately, patients, we request the medication, it arrives, but they don't, their disease got worse, it's progressed, or the patient dies before the medication arrives. And so this drug is available. And then a new patient comes to take this drug. So we use this amount that was already utilized. So again, this is some sort of saving as well. And also the compassionate use programs where we, especially when there's a new drug still not registered in the country, we agree with the company to provide like a patient support program where they give like 1 or 2 or 3 patients free of charge to build experience with this product in the country. So again, this is saved us around 1.25 million. So non-formulary management alone, as you can see, roughly saved us 9.5 million Qatari riyals in 1 year only. Another important aspect that we can save money in is dosage form selection. So switching, as simple as switching from IV to oral in antimicrobials. These 2 studies, one done in Europe and the other one was done in Saudi Arabia, about switching. And the one in Saudi Arabia is not only antibiotics, it's even including other like GI treatments like PPIs and others. Switching from, and it was a pharmacist-led. In both cases, it was a pharmacist-led service where pharmacists would review the orders, and wherever possible, they will request switching from IV to oral. And the acceptance rate was in both studies very high, more than 60–70%. And I think in the study on the left, the savings were more than 20%, or roughly 20% of those drugs budget if it was given IV compared to oral. And in the Saudi one, I think it saved more than 50,000 Saudi riyals in few weeks by saving thousands of IV vials or IV doses. And of course, it's better for the patient because we always know the IV is a risk for infection compared to oral. So even from safety perspective and indirect or non-drug direct medical costs, so admission or infection, this is another cost. So you're avoiding this as well. So switching is very important. We have another example. In our hospital, again, we switched from from IV to subcut. So the same drug for cancer, for example, is available as IV and available as subcutaneous. So the time needed for subcutaneous is much faster. So we calculated the savings generated from this. And we found that, for example, for one drug in 2 years' time, we saved around 3 million Qatari riyals, trastuzumab. And for another drug, trastuzumab, pertuzumab, where it came as combination in one vial subcut again, we calculated the savings in time, not in money. And we found that in the first year only of this drug, 1 year, we saved 4,800 hours of our daycare time. So the daycare unit or the short stay unit, 4,800 hours per 1 year. So that's a huge amount to be saved for the daycare unit. We're talking about 400 hours per month, I believe. So that was a great saving for us because we need the daycare for other patients who are on the waiting list and they have no other option to take except IV. So again, this was initiatives led by pharmacy or started by pharmacy, but again, in work with other healthcare professionals. So this is again the pharmacist role in value-based care. Equality, of course, high quality generics and biosimilars. I think this is straightforward. Again, pharmacists can start, especially for drugs that are available in the formulary. Can start and they have an upper hand in including high quality generics and biosimilars. And this study, for example, in 7 European countries or more, have shown that the savings in 5 years could be more than 7 billion euros. And in our hospital, we started to include several cancer medications. All of them are FDA or EMA approved brands. I mean, the generic brands, as generics or biosimilars. And this is working very well. And the list is getting bigger and bigger with time, especially for biosimilars. This data from the US just shows that, for example, the savings from biosimilars is increasing tremendously. So just between 2021 and 2022, it increased by $35 billion in the US. So that's a huge amount of money. And if we want to focus on the specialty drugs, especially the ones like in biologics, biological agents, immunology and oncology and hematology, etc., they're making a big amount of that, but not the majority. So if you take it, again, because the quantity is much less. So if you look at the 2022 data, it's 100 billion. That's a big amount, but it's 100 out of 410 or 408. So it's still like 75% of the cost is in traditional medicines as well. So this is important to keep in mind, because people always talk about those 100 and forget the 300. And there's a big room in those 300 for improvement. I think I have 3 or 4 slides left, so we will finish on time, hopefully. So another good thing about biosimilars that they also would lead to decrease in the price of the originator. So many examples in the US about biological agents like filgrastim or pegfilgrastim or bevacizumab. You can see the orange line is going down with time, like infliximab or pegfilgrastim. You can see it's going down, because when there is competition, of course, the originator product will also, their price will start to go down, which is at the end of the day good for the healthcare system. And again, pharmacy has a big role to play in introducing biosimilars and high quality generics. And I'm always saying high quality generics, because you don't want to bring any generic from a rubbish manufacturer that would be not effective for your patients, because that would lead to patient deterioration and higher costs in admission and hospitalization, etc., etc. So it's not smart. You're saving some money in the generic and you're paying much more in hospitalization. So always when you bring generics, you have to evaluate the generic not only against price, but you have to keep quality of those generics in mind. And it's very, very important. The good thing in biosimilars also that it will allow more patients to access the drug. So this simple example about filgrastim, very old drug that was available. For example, it's used for people who have low neutropenia or low white blood count. They used to give it for specific patients in the UK, in London, when it was the original product only. And it was restricted for high-risk patients who have a higher risk of getting infection, etc., etc. When it got available as biosimilar and the price got much better, they allowed it, like the NICE guidelines, etc., allowed it. They made the criteria easier. So for low risk, yes, you can give, or for medium risk, yes, you can give. So that led to 5 times more patients in London area receiving the filgrastim. So 5 times more number of patients receiving the drug in 2 years. In the same time, it's still saving 3 million euros per year. We got covered 5 times more patients and we saved money still, which was great. This is the ultimate goal that you want to achieve. So you're not only saving money, but you're broadening the access to the treatment for patients. So that's what I was saying. So it was allowed for lower risk cases. And this is the idea at the end of the day. And again, pharmacy, we have a big role to play in this. This is another thing that we can do, is to have pharmacist-led clinics. And this can be in diabetes. We have many examples on hypertension, cardiology, warfarin clinics, many clinics. So this is just an example from our hospital about multiple myeloma clinic, where we had a collaborative prescribing model. So our pharmacists for specific drugs and indication of multiple myeloma with very good experience in multiple myeloma, we got them a right to co-prescribe medications. So they cannot start or stop medications, but they can hold the dose, they can adjust the dose, they can refill the medication, they can order lab tests. So they manage the case. They don't start the treatment, but they manage the case afterwards. And multiple myeloma is becoming kind of a chronic disease, so they stay with us for a while. We just published last year the outcomes of this clinic, and they were impressive and better than what we expected. So patients, for example, for VTE prophylaxis, received the anticoagulation on time, much better. As you can see, the very significant improvements in that. Also, the time from diagnosis until they start the biphosphonates, the one that are used for prophylaxis from osteoporosis, because many of the cancer treatments affect the bones, so cause osteoporosis. Again, see, the time was reduced hugely, significantly. Sometimes doctors focus on the disease so much, so they forget the supportive treatments, like VTE prophylaxis or biphosphonates. So huge improvement in both, even compliance with vitamin D initiation, calcium supplementations, vaccinations related to prophylaxis of viral infections related to the disease like HSV are all got improved significantly with this clinic that we have initiated. So, and our doctors are very happy with the service. And any recommendations that we give for them in this clinic, they co-sign it like kind of blindly. So there is 100% acceptance rate. So again, you build trust, you increase your role as pharmacist, and you improve patient care, because all of these supportive improvements will lead for patients to stay on the treatment, on the active cancer treatment for longer, because otherwise they will have trouble because of the disease and because of the treatment itself without these supportive treatments. And so this will lead to deterioration, as we said, and higher costs. So again, this is value-based care. And after that, we have our all-in-one clinics for hematology and oncology. So now we see all cancer patients before they start any new treatment. They are seen in our pharmacist-led clinics in oncology and in hematology. My final slide is about, again, clinical pharmacy interventions. So not necessarily by clinics, even being on the ward, doing clinical interventions with your physicians for cancer patients is very important. This can be, again, dose adjustments, unnecessary medication stoppage, etc., etc., etc. We've done this study about the value of our clinical pharmacy interventions in our hospital, and we analyzed 1,300 interventions, and one physician was part of this analysis, and other clinical pharmacists who are not part of these interventions to avoid conflict of interest. And what we found that our interventions cause around 4.2 million cost avoidance. So cost saving, because that these consequences did not happen. And this was validated again by other professionals, including oncologists. And then this was over 3 months. So we projected this or extrapolated this to the full year. And we found that the annual overall economic benefit of the clinical pharmacy intervention in the INT'L was 14 million Qatari riyals. So that's roughly $4 million. $4 million economical benefit because of clinical pharmacies, which is a huge amount of money. Again, we were not expecting this before publishing this study. And the major driver was cost avoidance. And I always like cost avoidance, because cost avoidance is not only about, yes, we saved this money, but also we avoided consequences to be happening for the patient. So we avoided extended length of stay. We avoided deterioration and going to ICU, for example, for the patient. So we are also improving health. And when we are avoiding cost, we are also avoiding deterioration in patient case. We published this also in the Journal of Oncology Pharmacy Practice last year, or the year before last year, 2 years ago. It's just to show that we can do a lot in pharmacy. We are a cornerstone for value-based healthcare, and these are just what I presented are examples. There are even more things that we can do. So always when you work in your daily practice, think about value, think about what this treatment that you're giving for your patient is adding to their health, and also saving or maximizing efficiency in your healthcare system. With that, I conclude, and thank you very much.
Thank you very much, Dr. Anas, for this great presentation. Thank you, Dr. Anas, for this great presentation. Sorry for it was just a lag in transition from the speaker ready room to here. Thank you. It was a great presentation, very informative, very structured. And we have a couple of questions on the chat, if you allow me to address them to you. The first question, is the pharmacist authorized to change a chronic CS medication without going back to the physician? I think maybe it means a controlled substance medication, if I understood the question right.
Yes, I'm not sure if it's controlled substance. So in principle, if it's, pharmacists in our region still do not have the authority to prescribe, although this model has been established elsewhere, for example, in the UK, where there's independent prescriber model. And actually starting from next year, 2026, all pharmacists graduating with an MPharm degree in the UK will be independent prescribers automatically. So they can prescribe medications without even co-signature from physician. But in our region, this is not valid yet. So changing a medication, if the question is related to changing an active ingredient of the medication, no, it's not possible. You still have to go to the doctor and ask them to change that. But again, if you prove yourself, if you prove your value in the healthcare system, doctors will listen to you. They will. As I told you, our acceptance rate in general is above 90%, in the clinic above 100%. So there is this trust that is when the pharmacist is calling me, yes, they know better or they know well. I trust them, so I will follow. But we cannot change, no, unless if it's a brand. Yes, we can. If the prescription was for X brand of, for example, coamoxiclav, yes, I can change it to another brand without asking the doctor, because by law, actually now in most of our region, it should be by generic name. It shouldn't be by brand name. So if a specific brand was prescribed and you want to switch to another generic, either because the patient doesn't want to pay more, for example, or because it's not available, or the insurance is not allowing, you don't need to go back to the doctor. For controlled substances, it's always more tricky. So if the question was controlled substance, so you have to be more careful with controlled substances because they are strictly governed by Ministry of Health and Ministry of Interior. So you have to be very careful with that.
Another question is regarding if you're having a checklist in your hospital that makes the pharmacist deliver his work with patients and tailored to the time that he allows for patients. Also, what is the time slot from your perspective that will be efficient and sufficient for pharmacists to focus on his work and patient to ask his question?
Yeah, that's not an easy question to answer. Of course, we always talk about examples and the principles, etc., which are great, but in reality, we know that we are under pressure. We have hundreds of, in big hospitals, hundreds of patients are coming every day, and every patient comes to us at the end of their journey, and they will go to the lab, they will go to the doctor, and then they come to the pharmacy exhausted. So they are واصلة معاهم لهني, they want to finish and take their medication and go home. That's a reality, صح? But again, with time, when they feel the value of the pharmacy service, and this was not easy to achieve in one day. It's something that you build. That no, Allah, the pharmacist told me something about my drug or about my treatment that actually I didn't hear about from my physician or from my nurse, and it was very useful for me. And alhamdulillah, I receive, of course, I receive complaints, but I receive many letters, which is unusual. People like to, by nature, people when they are not happy, they like to complain. But when they are happy, they leave happy. They don't send you thank you. But alhamdulillah, I was happy that from every month I receive 1 or 2 thank you letters or from our patient service counter, where they usually receive the complaints. We receive some good feedback about pharmacy, and sometimes they mention pharmacist Randa, pharmacist Ahmed, and I'm really happy when I have that. So yes, you have to build this. Now you have to balance, of course, between the time that you have and the patients in the queue and the service that you provide. So yes, you have to be efficient, but you don't have to be superficial as well. So this balance is depending on the context, on the need. Yani if the patient's starting a new oral chemotherapy, for example, for the first time, we might spend with them sometimes 15, 20 minutes on the window, in the counter, because you have to go through details of the drug, of the side effects, what to do. If it's not only you tell the patient, well, this will cause you diarrhea, it will cause you hair loss, and you stop. You have to, yeah, if this happens, you can do this. If this happened, you can do that. So yes, you have to be as comprehensive as possible, but also keeping in mind the other patients as well. Now, having a checklist is doable. We do have like a major, let's say, I wouldn't say a checklist per se, but a major items that we would like to cover in every single patient that we do, because we have in our system, in our electronic health records, we have what we call patient counseling form. So after finishing the counseling, you need to document your counseling. So you need to tell the patient what you've done. So there is some areas like, yes, you talked about this, yes, some sort of checklist, you can call it electronic checklist. It makes it easier because, again, the patients, pharmacists are busy to keep also writing. So if you make this electronic with drop-down lists, so they can just select, that will make it easier for them to document this, because it's useful for us also as administration to know what's going on, what interventions our department did, etc. So always this is part of efficiency and simplification. Make it electronic, make it as simple as possible. But yes, it's good to have some sort of checklist so you can make sure that you're not missing anything.
Yeah. Thank you, Dr. Anas. And that's why we believe that such programs and such, the role of pharmacist is really, really important. It goes beyond just dispensing or fulfilling the prescription. So thank you for your lecture. I think we're running out of time. So
thank you very
again,
much.
thank you, Dr. Anas, for your great time and your great presentation. And now allow me to introduce our second speaker for today and the lead instructor of the program, Dr. Rafat Youssef. Dr. Rafat is a consultant and a professor of strategic management at the Arab Academy of Science and Technology in Egypt. He had been a physician psychiatrist in Abbasiyah Psychiatry Hospital in Cairo before he shifted his interest to the field of strategic management. So please allow me to welcome Dr. Rafat to the stage, and thank you, Dr. Rafat, of course, for your time.
Good evening, everybody. It's a pleasure for me to be with you today. Many thanks for Organon for giving me this opportunity to be with you. We are going to talk about a very nice topic, which is patient communications. I would like to start with a very nice quote regarding communication. If you want to kill a relation, just stop communication. Again, if you want to kill a relation, just stop communication. So if you need to keep a healthy and good relation, a sustainable relation, you have to focus on communication. In business, we have a very nice expression regarding communication. We call it 360 communication. And 360 communications, it means how to communicate both online and offline. So we are going to talk about both of them. And please give me your attention and your concentration, because it's a very important topic for everybody to succeed, which is communication. It's not related only to patients. It's how to communicate with your peers, with your colleagues, with your subordinates, with your boss. This is the art of life, how to communicate. Regarding our table of content, we are going to talk about different communication styles, verbal and non-verbal. We are going to talk about active listening skills, because this is one of the most important communication skills, is listening. Then how to manage different conversations and communication with difficult personalities. And we will mention one of the role models regarding communication, who was Barack Obama. And finally, managing communications in the era of social media. Let's start with this slide. This is 1960, and it was the first presidential debate in the history of US between John Kennedy on the left and Nixon on the right. That time, not all the houses in USA included the TV. Some houses had TVs and some houses have radios. People who listened to this debate in the radio thought that Nixon will win, while people who watched this debate in the TV assumed that John Kennedy will win. Who won at the end of the day? Before telling you who won, let's talk about why people who listened to Nixon in the radio said that Nixon should win. They said because he is a wise man. While people who watched this presidential debate in the TV, they said that John Kennedy is a prince. Why? We are talking here about the body language, how he's sitting on the chair, his back is on the back of the chair, the crossed legs, the crossed arms, the color of the suit itself. So here we are talking about the importance of body language, the importance of body language. And this is also a very nice photo about Barack Obama. This photo has one word only, the president, which was wrote on the back of the chair. But actually, there are here 5 positive messages. Can you send me, or can you write on the chat, what are the positive messages that are here without any word? Can you tell me? Or can you send me on the, write on the chat? We have here 5 messages. Okay, let's start with the first message. There are here some ladies and some gentlemen. So the message here is, I'm working with both genders and there is no discrimination. The second message, I have equal number of ladies and equal number of gentlemen. The third message, I always work in a team. The fourth message, I'm a good listener, because if you analyze the photo, actually the photo is focusing on his left ear, which is a little bit bigger than the right ear. That's why he is communicating the good listening skills of Barack Obama. We have 2 photos in front of Barack Obama for Abraham Lincoln and George Washington. This is the successful past, and I will be the successful present. So actually, there is no text written here, but we have 5 or 6 positive messages. Let's go to this important slide. We are talking here about the different tools for communication. We have voice, we have content. It means the scientific data. And we have body language. And actually here we have a question you have to think about. What if we have 100% as a total weight for the 3 items? And we need to allocate weight for each item. This is an example, and actually this is not the right answer, but I'm writing in order to communicate. I need a style like this. So what do you think the importance of voice in successful communication, and the importance of body language, and the importance of content? I don't know if the attendees can write in the chat or not, because I asked them for the previous question, but nobody wrote in the chat. So Are they able to write in the chat or not? I'm asking the coordinator or the organizer of the event, if you can tell me. So here, some people will be very surprised with the result. Very surprised with the result. Because most of you will focus on the content, which is the opposite. Voice constitutes 38% of your success in communication. Body language is 55%, while content is 7%. It does not mean that the content is not important, but it means that a content without a good ability to communicate is nothing, because the content actually is 7%, and the way of delivering the content is 97%. That's why you have to focus on how to deliver actually the content. Usually we see this in some medical conferences. We have a very professional and highly knowledgeable professor, but he or she lacks the ability to present. That's why most of the attendees will lose the attention. Sometimes we can find another professor maybe with the little amount of or moderate amount of knowledge, but he has a charisma, he has a good ability to communicate. That's why he's getting the attention of people all the time. That's why we are asking you to focus on how to communicate, besides what to be communicated. This is a nice communication test or a test for communication. We have here 9 boxes. Please select one box that you think it's similar to your way of thinking. It's appealing well for you. So every one of you, please select one from the 9 boxes and keep the number in your mind, because I'm now going to proceed with each box and what does this box mean regarding your personality and your way of communication. Ready? Let's start with box number 1. If you did select box number 1, you are introspective. Introspective, it means introvert, not social, and you are sensitive. And this style in communication needs to do a little bit more effort in order to approach and penetrate others. Number 2, independent and unconventional. And this style is a little bit successful in communication. Number 3, dynamic, active, and extroverted. And this style in communication is very, very successful because actually they have a good ability to penetrate others. Number 4 is down to earth, well-balanced, and harmonious. And this person in communication usually is described to be a wise man with high likability or acceptance. Number 5, professional, pragmatic, and self-assured. Pragmatic, it means he is someone that is using decisions based on what logic is pushing in. And self-assured, it means self-directed. He's not going to be affected by others. He is self-directed. And usually these people, they have very high self-confidence. Number 6 actually is about peaceful and non-aggressive. But this style in communication a little bit seems to be passive, and that's why some aggressive people can actually control this style. So this style, you have to control being peaceful and non-aggressive in order not to be misunderstood by others. 7 is a very professional and successful style in communication. It's carefree, playful, and cheerful. Because actually people, usually they like this style in communication. Number 8, maybe it's more suitable ladies, but not with gentlemen. It's romantic, dreamy, and emotional. So here you have to be a little bit more pragmatic, more rational, more logical, because actually being pure romantic for others, it means You are not related to life, to be down to earth. Finally, style number 9, analytical, trustworthy, and self-assured. And from my experience in conducting this survey or test, usually people who prefer this style, usually most of them are engineers. It does not mean that it's restricted to engineers, but because engineers a little bit, they have a more organized way of thinking. But this style, if actually is exaggerated, the person will be skeptic or obsessive. So we need to control this in order not to go into the direction of skepticism or obsession. Now we need to talk about rules of successful communication. I'm a pharmacist, I'm a doctor, I'm an ordinary person. I need to be successful in communication. I need to be able to start, to create, and to sustain good relations with others. The first rule is you have to communicate with a professional voice. This is very important for all of us. You have to know how to use your vocal skills. And here we have 5 vocal skills. The first one is rate of talking. Do we have a normal rate of talking? Yes. Usually a second, it can have 2 words. So the normal rate of talking is from 100 to 120 words per minute. This is the normal rate of talking. What about the volume? We have low, we have moderate, and we have high. It's based on the size of the room, number of attendees, and so on. The most important vocal skill, and you have to focus on, and you have to develop, and you have to master, is tone of voice. We have 2 tones of voice. We have monotonous tone, and we have non-monotonous tone. I'm going to play both of them. Good afternoon. My name is Rafat Yusuf. Today I'm going to talk about communication. And do you know that communication is very important in life, and it actually can be considered to be a critical success factor for success and achievement. This is the monotonous speech. My name is Rafat Yusuf. Today I'm going to talk about communication skills. As all of you know, communications are very, very important. This is the non-monotonous speech. By the way, the tone of voice is the most challenging vocal skill to develop and to learn. That's why you have to focus on this, especially, by the way, on the online meetings. Because actually, I'm a professor of management, strategic management at the Arab Academy. We have both programs. We have online and offline. Some instructors, while they are conducting offline sessions, they are okay, a little bit okay. Once they move to the online sessions, actually, it will be a disaster. Why? Because they do not have good communication skills, especially the non-monotonous speech. What else regarding professional vocal skills is the text. Communication, this is a tech, something that is repeated without any need. It may be a voice or maybe a word, like, okay, let's talk about communication. Okay, communication, it's about listening. Okay, so you have to avoid verbal text. And finally, pauses. You have to make a pause of 1 or 2 seconds after an important expression or word or percentage to let your attendees think about this number or this important word. So we have 5 vocal skills. The most important one of them is the volume. Try to have the non-monotonous speech. This is Martin Luther King, and actually it's the famous talk, I have a dream that one
day this nation will rise up creed. We hold these truths to be self-evident that all men are created equal.
Did you see how he is using his voice and his tone of voice? I have a dream that this nation will rise up. He's here focusing on some expressions. The second rule in successful communication is you have to smile. You have to practice smiling. But actually, you are talking about normal smile, not fake smile. And actually, this is a very nice photo to differentiate between Meg Ryan, which is picture 1, and picture 2. I cannot memorize the name of this lady. So one of them has a normal smile, while the other has a fake smile. What do you think? Meg Ryan, is it a normal smile or it's a fake smile? What do you think? Meg Ryan has a fake smile. Why? I know that all of you maybe still remember some data from the anatomy. Regarding the anatomy of the face, we have two muscles in the face with the same name, with a different extension. Orbicularis oris around the mouth and orbicularis oculi around the eye. And actually, in the normal smile, both of them will contract. So the mouth is bigger and the eye will be a little bit narrow. While in fake smile, the only muscle that is going to contract is the orbicularis oris, so the mouth is wide, while the eye actually is not narrowed. Let's talk about this photo. What do you think? Is it a normal smile or a fake smile? Once here we have wrinkles around the eye, it means that the orbicularis oculi also contracted. So this is a normal smile. Contraction of the orbicularis oris, that's why the mouth is big. Contraction of the orbicularis oculi, that's why the eyes are very small. This one, it's Abu Hanan Zebd smile. It's a little bit a fake smile. We call it Zebd smile. Zebd, it's related or from zipper, because the upper and lower eyelids actually are parallel to each other. The third rule in communication, you have to communicate with fairness, with equity. I'm dealing with patients. He or she is a patient, apart from being rich or poor. So I should not discriminate in the way of communication between a poor and a rich patient. He is or she is a human being. So I have to deal with him in a very respected and professional way. Let's see this video. It's a very nice video. It's an experiment that is saying that even animals feel the inequity. Even animals feel the inequity. Let's watch this nice video.
Is the monkey who gets cucumber. The one on the right is the one who gets grapes. The one who gets cucumber, note that the first piece of cucumber is perfectly fine. The first piece she eats. Then she sees the other one getting grape, and you will see what happens. So she gives a rock to us, that's the task. And we give her a piece of cucumber, and she eats it. The other one needs to give a rock to us. And that's what she does. And she gets a grape. And she eats it. The other one sees that. She gives a rock to us now, gets again cucumber. She tests her rock now against the wall. She needs to give it to us. And she gets cucumber again.
He did repeat the same experiment in order to make sure that actually he's going to do the same action before. Even animals feel the inequity. Let's here to go to the third rule of communication. Communicate with the positive words. And actually we have very nice expression in business, the power of positive words. Here, this is a photo for John Kennedy and his family. The lady is who actually sat on the left. This is the mother of John Kennedy. Her name was Rose Kennedy. She wrote on the door of the room of John Kennedy, while he was 7 years old, Mr. President. That's why she is trying to convince him, even if he's still a kid or a child, you will be the president of USA. And actually, this happened. So this is a good example of how to use positive words to motivate, to enhance, to convince. And actually, as you know, and being a psychologist, usually we talk about this frequently with patients. Once you think in a positive way, this thinking on the conscious level will penetrate your unconscious. So try to talk with yourself in a positive way. This will enhance your thinking, and actually it will move to the unconscious. This is George Bernard Shaw. This is George Bernard Shaw. George Bernard Shaw has a very famous novel. It's called Pygmalion. An ENT doctor in England. His name was Henry Higgins. He was penetrating or entering his clinic in London. While he's entering his clinic in London, he saw a very, very beautiful lady called Lisa. She was selling flowers. But what was frustrating for Dr. Henry Higgins is that Lisa, despite being very beautiful, she was not classy. He started to think, can I convert this unclassy lady to be a classy lady within 6 months? And actually, he started to do what he thought about. I will try to teach her how to walk, how to talk, how to eat, how to dance. And after 6 months, I will introduce this lady as a princess among the British community. What happened at the end of the day after 6 months? Most of people, they started to think about this lady to be a princess, and most of the gentlemen were trying to get married with her. It means using positive words will move one person from the extreme right to the extreme left. And in our Arabic culture, يطلع من الفسيخ شربات. In literature, this is called Pygmalion. But in management, we call it Pygmalion effect. Pygmalion effect. And by the way, it was converted to a movie. I think it's My Fair Lady. And it's a play in Egypt. It's called Sayyidati al-Jamila. Fuad al-Muhandis is trying to change the style of Shawikar from being an unclassy person. أنت الكلب الكبير. She cannot say al-qalb. She's saying أنت الكلب الكبير. But actually, at the end of the day, he was very successful using the positive words to move this lady into to be a princess. This is Abul Qasim al-Shabi. I think all of you know him. Actually, he has a very famous part. It says, إذا الشعب يوما أراد الحياة لابد أن يستجيب القدر. And actually, it has a very famous also another quote is saying that من يتهيب صعود الجبال يعيش أبد الدهر بين الحفر. Despite this man, he was born with atrial fibrillation and he died at the age of 25. But actually, he was most of the time talking in a very positive way. It's a very fantastic example of how to use the power of positive words. We have to do this with our patients because we need to motivate them, especially if we're going to communicate them some negative messages. Communicate with entertainment. It's a very important rule in communication. People in general hate education. And this info usually irritates some people, but this is the fact. Overall, people do not like education. And that's why if you are going to purely educate people, nobody will pay you attention except very, very few number of people. But in order to attract the majority of your attendees, you have to apply this rule, which is entertain and educate. Entertain and educate. And actually, you have to focus on the order. We started with entertain and not with educate. If you can combine entertainment with education, people will give you their ears and they start to give you their attention. This is a very nice example of how to educate with entertainment. Here we are talking about the education as a pharmacist. For example, I have a patient in my pharmacy and I'm talking to him face to face. So this is an example of how to apply the entertain or the situation for the entertain and educate. Or I'm actually communicating with my patients through the social media or through my website. So I'm using some videos, some posts. I need to apply this rule. Here we have an example of a company called Blendtec. Blendtec is a company that is specialized in home appliances. Actually, the person actually who will start the video right now is the CEO of the company. He started to produce high quality home appliances. He started to sell it online, but actually sales were very limited, and the same for the offline. Someone advised him to create a video to tell people the advantage of his products. Here he was talking about a blender. Let's talk and let's move and watch this video to know what is entertain and educate.
Will it blend? That is the question. I love my new iPad. It does a ton of cool things. But will it blend? That is the question. Doesn't quite fit in the jar, but I can take care of that.
No!
I knew I could get the iPad in a Blendtec Total Blender. I think I'll press the iBlend button. Woo. Oh, pad smoke. Don't breathe this. Ah, that was one tough pad.
I will tell you about the results of this video. 30 millions viewership rate in 1 month. And that's why in digital marketing, we call this video to be a viral video. And the sales of the product or the company were increased 700% in 1 year. This is a frank example of how to entertain and communicate. I'm communicating here that my products are very powerful, are very durable, without any word through this movie. Communicate with enthusiasm, because enthusiasm is infectious. So while you are talking about something, about idea, about topic, any topic, you have to project enthusiasm. We have 3 issues that can project enthusiasm. I'm going now to do the opposite, and you will think and try to think about the 3 factors for the enthusiasm. Good evening. Today I'm talking about communication skills. Communication skills are very important for all of us. Communication skills include both verbal and non-verbal. This is a non-enthusiastic attitude. Let's go to the other side. Good evening. Today we are going to communicate and to discuss communication skills. We have two types of communication. We have verbal communications and we have non-verbal communications. Here I'm using 3 tools for projecting enthusiasm. The first one is animated face. Try, please, 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 try to avoid the poker face. Try to avoid the poker face. This is number 1. Number 2, so your face should be very animated. Number 2, non-monotonous speech. So you have to play with your voice. The third is professional hand movement. And actually, when I'm trying to mention the 2 types of communication, I'm using the finger counting, which is a professional tool. You can use this. I have 2 types of communication, verbal and non-verbal. So in order to project enthusiasm, you have to focus on these 3 tools: animated face, professional hand movement, and non-monotonous speech. Communicate with focus on body language. This is a very crucial tool in communication, and it's actually responsible for 55% of your success in communication. Here I have a couple of stories regarding the importance of body language. This is Hitler, and Hitler used to hold his head usually with his left hand down, not here, not any place. It's the same way as actually he's holding his head here. He actually was not aware why he was holding this head with his left hand this way. There is a very nice report about the personality of Hitler. It was created by CIA, and actually it's available online. Go to the Google and write CIA report on Hitler personality. You will find the rationale. And actually, the rationale is something unconscious, and that's why Hitler was not aware with the info that I'm going to mention. Hitler actually has or had only right testicle. He did not have a left testicle. And unconsciously, he feels a weakness on his left side. It means that this is one of the defense mechanisms of the unconscious. The unconscious is trying to hide the weakness on his left side. So it's a very nice explanation, and it indicates that body language is very important, because sometimes we do not have a good ability to control it. It's unconscious. That's why if you are going to, for example, you are a head of pharmacy and you are going to recruit someone to work with you in the pharmacy, you are doing a selection interview with him. Try to put him or her under pressure, and then to interpret the facial expressions, the hand movements, because actually body language does not lie. Another story to mention the importance of body language. This is Bill Clinton and this is Monica, and you know that there was a scandal, a very famous scandal, sexual harassment between both of them. And actually, he was trying to defend himself in front of the Congress, a sort of interrogation. He's denying this issue verbally. While he's denying verbally, he did a gesture or a body movement, which is touching the nose. How many times? 26 times. And this sign in communication, it's a sign of lying. So he is saying something verbally while he's expressing the truth non-verbal. And that's why it's very important to focus on interpreting the body language of other people. This is our facial expressions. We have 6 types of emotions. We have anger, fear, disgust, happiness, sadness, and surprise. Actually, we need to classify all of them into either positive or negative. Anger is negative. Fear is negative. Disgust is negative. Happiness is positive. Sadness is negative. Surprise is 50% negative, 50% positive. Ignore the surprise. We have 4 negatives, or 4 negative emotions, and we have 1 positive emotion. That's why we have to try controlling our default, because our default goes with the negatives. So you have to control your negative emotions. And this is an important issue because actually our facial expressions communicate what we feel. No, we have to train ourselves. If we have negative emotions towards someone, we are trying and we have to develop and we have to teach ourselves how to control this negative emotions, how to prevent our faces and our facial expressions from communicating negative emotions to others, because it will hurt the relation between me and others, either patients or even other people. This is a slide about what does every eye movement indicate. If the eyes are moving up, this is it means someone is trying to recall a picture. If it goes side to side, someone is recalling a sound. If it goes down and to the right, recalling a situation or a feeling. Talking with yourself, the eyes will move down and to the left. The challenge here is that eye movements happen in a fraction of a second. So you have to try to catch it as fast as you can in order to interpret how other people or how the person in front of me is thinking. Here we have 7 common signs of lying. The first sign of lying is mouth cover. Maybe as the interpretation of a lot of experts, maybe this is because the unconscious is trying to prevent you from lying. So it's a sort of unconscious movement. The unconscious is telling you or is trying to ask you, please do not lie. That's why he's moving the hand this way. The second sign for lying is touching your nose. Eye rub, you are touching your eye while you are lying. Ear grab, you are touching your ear while you are lying. The coming sign is very common in the Arab countries. It's neck scratch. While you are lying, you are scratching the back of your neck. This one also is collar pull. While you are lying, you are trying to move or to do this movement as if you feel you cannot breath. You have to have breath, and that's why you are trying to pull the collar of your shirt. The last sign for lying is finger in mouth. It means that you have to focus on your patient while he is talking to make sure that he is not doing any of these signs of lying, because actually maybe he's lying, but actually you cannot predict from the content itself, but you can predict and you can actually make sure from the facial expressions and the signs of lying. We have a very famous British quote is saying, one size does not fit all at all. One size does not fit all at all. It means do not use the same strategy in communication with every patient. Every patient has a key, and actually in psychology, We call this personality key. So to succeed with everybody, you have to know the key of this personality. In order to do this, you have to customize your communication according to how the customer think and the personality profile of the customer, the patient here. For example, some patients, if you give them more details, they will be convinced and satisfied. Other patients, if you are going to give them more details, they will be frustrated and dissatisfied. Some patients, to succeed with them, you have to start a personal relation. Some patients, if you started with them a personal relation, you will fail in communication with them. So you have to customize your style according to the personality of the person in front of you, either a patient, a peer, a colleague, a subordinate, a boss, and so on. We have here a very famous personality assessment theory called DISC, D-I-S-C, D-I-S-C. It's a classification for people based on 2 factors. And the two factors will generate 4 styles. So we have 2 factors and we have 4 styles. Each factor either high or low. So 2 factors and 4 styles. The first factor is assertiveness. Assertiveness, it means in Arabic, al-hazm, your ability to say no, to deal with people, to take decisions, to deal with problems. It's called assertiveness. And the opposite of assertiveness is being passive. A passive person cannot confront, cannot take decisions, cannot solve problems. While the assertive person can take decisions, can confront other people, can actually solve problems, can also take risk. This is the x-axis. The y-axis is about responsiveness. And responsiveness, we are talking here about emotions. So we have drivers, and this style, according to the other names, is called D-style, because actually we have 2 types of describing the person. We have DISC and we have this names, and both of them are the same. Drivers, actually, it's D. According to DISC, it's D, and D stands for dominant. Expressives, we call them I, based on the DISC. But I'm going to the drivers again. Drivers, they have very high degree of assertiveness with no emotions. And this person actually appeared to be aggressive. High assertiveness, no emotions. What about the expressive or the I style? Very assertive, yet is people-oriented and emotional. That's why actually we can consider this style to be a little bit a balanced style. Amiables. I want to share the name in Arabic, because amiables in Arabic we call them al-wadud. Someone who is very soft, very nice, non-aggressive. He has very high degree of emotions, but no assertiveness. And by the way, I'm talking now about the extremes, because sometimes you can find someone who is amiable, but actually is a little bit very close to be analytical. I'm trying to mention this with the mouse here. I'm amiable with a tendency to be analytical. If I'm here, I'm equal, expressive, and drive, and so. Analytical person, limited assertiveness and limited emotions. And actually, these people, usually when they talk, they look like a robot. Okay, give me a time to think. I need some details. This is the way. Let's talk about each of them. Driver or D-style, very famous personality of a businessman who belongs to this style is Elon Musk. Decisive, serious, is not laughing at all, opinionated. He's very impressed with his opinions, demanding, do this, do not do that. Please prepare this medication for me as soon as you can. Assertive, focus on the results. Competitive, he's not caring about anybody except himself. Political, is thinking how to approach others, how to get the best of others. Do it my way. Do not think, apply what I'm going to tell. Pushy, task-oriented, intense, seek power, make own decisions, conservative dress, but usually they prefer wearing professional and classical suits. Why? Because they want to express that we are the best. Achievements awards, if you go to their offices, they put some achievements awards on the wall of the office. Expressive. Before leaving a driver, I want to tell you how to deal with a driver. First, you have to listen to him, because actually he wants to express himself. You have to be assertive, not passive with him. You have to praise them. You have to give them options. They do not like do that. So if you have a driver patient or a D patient, you have to give them options. You have to be fast with them. Do not give them details. Focus with them on results. Fine. Let's go to the expressive. Usually they have high assertiveness and high emotions. Charismatic, talkers, outgoing. They like jokes and humor, energetic, yet they are impulsive. People-oriented, storyteller, fun-loving, extrovert, enthusiastic, act quickly, take decisions. They like the big picture. They like and prefer open door to deal with others. They like testimonials. Testimonials, it means reviews of others regarding anything. How to deal with expressive? You have to be very cheerful with them. You have to be smiley. You have to focus with them on results. You have to behave professionally. This is the best way to deal with an expressive style. Expressive, according to the desk classification, is the I style. Analytical, this is Warren Buffett. Warren Buffett is an American billionaire, and he is the CEO and founder of Berkshire Company. It's a very big company in USA, Berkshire. And by the way, he retired last month from being the CEO of the company. Analytical persons, usually they are skeptic. They like facts, they like figures, they like numbers, they are thinker, they are orderly, very organized. They are cautious, they are slow in decisions, they are disciplined. We call them sometimes perfectionists. They like details, very slow, and that's why I told you about their style is like a robot, and that's why they are monotonic. How to deal with them? Try to keep the relation as professional as you can. Do not deal with them as friends, because this will make them a little bit obsessive and skeptic. Why this doctor or this pharmacist is trying to create a relation with me? It means that he's going to deceive me. So you have to be very cautious with this style. Give them more details. Wait for the decision making. Give them definitely and always written proofs, not oral proofs. And by the way, to succeed with analyticals, the best way is to be very patient, very patient. They ask you a question, then they will repeat the question again after a while. Why? They are skeptic and obsessive. They are trying to make sure that you are telling the truth. So they are very skeptic about everything, everything. But by the way, they have this is a very bad disadvantage. But on the other side, the advantage, if they started to trust you, they will be very loyal to you. That's why you have to be patient with this style. The last style, we call it, and by the way, according to the desk, analytical actually is the C style. C style. C, it stands for compliance. The last factor is amiable. amiable, which is in the, according to the disc, it's the S style, steady. Assertiveness is limited. Emotions are very high. Easygoing, warm, agreeable, no get ego. Light-hearted, risk avoider, quiet, cooperative. We call them family person. They believe in and accept open door to deal with people. Casual dress, relaxed, friendly, soft-spoken, people-oriented. How to deal with amiables? You have to start a personal relation. The second issue is try to show interest in their personalities. And I will give you, all of you, a very nice advice to succeed with amiables. Try to take the decision on their behalves. Try to take the decision on their behalves. Because if you give them the chance to take a decision, they will never take a decision. Why? Because actually they are passive. They do not like take decisions. Both analyticals and amiables, they hate decisions because actually decisions need assertiveness and actually they lack assertiveness. Here we have a very nice videos regarding each style, as if you saw your patient in the elevator. So it's a very short time. How can you diagnose your patient to be analytical, expressive, amiable, and so on? Let's start.
We've all been waiting on an elevator and seen the girl who presses the button, steps back and looks at the button again, then presses it again, and again and again. Yeah, that's a D style. She has places to go and people to see. She's probably always in a hurry, so then she'll tap and hold the button, frustrated, thinking she can actually make it move faster. D styles are dominant, direct, and results-driven people who want to control their environment and then do something to make a difference in their world.
This is the D style, or actually we call it dominance or driver. Let's move to this style.
She is Talky Talkerton. Once the doors open to the elevator, she's the one who turns around and starts talking to nobody in particular about pretty much anything. She's an influencer. When the elevator stops, she's the jokester who quips, "Third floor lingerie, enjoy your day." Now, not all I styles are cheesy people who tell mom jokes all the time, but you see what I mean. I's draw energy from people and love to engage. She is
the I or expressive style. Let's move to the third style. I'm moving a little bit.
She's stable, steady, and keenly aware of her surroundings. She wants everyone to be happy, and she thinks it's her job to make it so. She's the one holding the elevator door open to make sure everyone who wants to get on can do so at their leisure. Meanwhile, Miss D's in the back huffing and puffing about needing to get to her meeting. The S will even take the stairs if there's not enough room for Miss I, who keeps everyone waiting while she finishes her mocha latte frappuccino thing. Harmony and steadiness are a big deal to the S.
By the way, this movie actually showed the four styles.
She's stable.
This is the amiable or S style. Let's go to the analytical.
She's the quiet one. She's kind of off to the side, standing in the front of the elevator, looking at the plaque that reads, "Maximum weight, 2,500 pounds." She's calculating body weight. Uh-oh. If one more person gets on, we're gonna go down. She's on a schedule, but she's allowed herself plenty of time. She's compliant, she knows the rules, obeys the rules, and wants everyone else to do the same. Look at her. How cute.
Let's do it
She's the
regarding a patient, but actually, Dr. Hanan, I will escape the poll in order to save time. So a patient enters the pharmacy with a sense of urgency. They approach the counter and say, "I need this, my blood pressure medication, filled immediately. I have a meeting in 10 minutes. I cannot afford to be late." What is the quickest way to get this done? The patient appears assertive and confident, making it clear that they expect prompt service. The pharmacist responds efficiently, prioritizing the request to ensure the patient can leave quickly. Which style? You actually know the answer, please send C, and actually take quick decisions. This is not compatible with each other. C cannot take decisions quickly. What else? Some people actually are talking about analytical. No, it's a driver. Some people actually, this is the driver, by the way. Why? He's very assertive. He's very aggressive. He needs quick action. Let's go with the second style. Second style. Most of the answers actually are D, which is right. A patient walks up to the pharmacist with a big smile. Actually, if we stop here with a big smile, so we have two options. This statement will exclude the other two options. The two options here, either amiable or expressive. Let's think about the other dimension. If this person is assertive or can take decisions, he will be actually the expressive. If he lacks assertiveness, he will be an amiable. In like conversation with confidence and assertiveness, so high emotions and high assertiveness without completing the case. This is the style of. Can you write the right answer on the chat? Is it D, I, S, C, or driver, expressive, analytical, amiable? What do you think? No, this is not the D. Some people actually, they have good answers. Smile, actually, this is not the D. D, usually, they do not smile. But actually, this is, and here also is animated and friendly. This is the style of, actually, the expressive or the I. A patient approaches the pharmacy counter with a nice smile, looking a little bit hesitant. So here, he is smiling, but a little bit hesitant. Without completing the case, once we have good emotions, but the assertiveness is limited, once he is hesitant, it means he has limited limited assertiveness. This is the amiable style, amiable, or the S style. They say, I'm here to pick up my anxiety medication, but I have some concerns. I have been reading about possible side effects, and I'm more worried about how it might affect me. Can you explain? And so this is the amiable style. The last one, a patient carefully examines the packing of their medication at the pharmacy counter. They approach the pharmacist and ask, excuse me, could you tell me the expiry date of this medication? Also, how should it be stored to ensure it remains effective? I want to make sure I'm using it safely. The patient is detail-oriented and wants to ensure they are all the necessary information before proceeding. The pharmacy or pharmacist provides through answers discussing storage conditions and expiry, appreciating the patient diligence. So here, this is a style of C, or the analytical style. How to deliver bad news to your patients. I'm trying to finish, Dr. Hanan, in 5 or 10 minutes maximum in order not to exceed my time. So here, actually, we have a very famous protocol. It was developed by 3 Indian doctors. All of them were working in the field of oncology. So if you are trying to tell your patients a little bit negative message or negative news, it's a breaks protocol. Backgrounds, you have to have a background about the patient and about the issue. Then rapport, you have to start creating a rapport or ice breaking, explore the issue in details, announce the statement, you are diabetic, you are, and so. Kindle, make sure that he or she actually is aware with the condition. And finally, summarize. Very nice topic. And I think, Dr. Hanan, we will create a WhatsApp group for the team, for all the attendees. We continuously will give you some articles and some details about what we discussed during this session. This is the last part that I'm going to communicate with you. It's a very short part, but you have to start writing right now. If you were not writing the first part of the session, start writing here, because I'm going to tell you some important websites. Definitely you will be in a need for them. Here I need to brand myself or to communicate with my patients through the social media. And actually I need some tools. I'm not a marketeer. I cannot brand myself or my content. So I need some tools. Actually, I have two issues that can help us, or two tools that can help us. Using freelancers, and in Arabic we call them al-huwa, or using the AI. AI, we will talk about it, I think the third session, but here we are talking about freelancers. We have some freelancing websites. You have to write these websites, and you have to know how to use, you have to visit these websites. You have to start evaluating the work of different people on this website, and you have to select someone. I need someone that can help me in creating a post, a banner, a PowerPoint presentation, to design a logo for me, to design for the company, a slogan, anything you want. You can find someone who is professional in this. This is the first website. It's called Freelancer. The second is Upwork. The third is Fiverr. And Fiverr, the name here, it's from five, because most of the services that will be offered through this website will cost you $5. The Arabic version of Fiverr is Khamsat. We have also Mustaqil. We have also people per hour. And this is also a very nice tool. It's called Canva. If you cannot use Photoshop, it will be a very professional and important tool for you. It contains a lot of templates. I need a logo, so it will give you hundreds of or thousands of templates. You can select a template, and then it will give you the chance to edit and to change anything. Templates, Facebook posts, anything you need, you can actually find it here. I think I have to stop here, Dr. Hanan, because actually I exceeded my time. I have some questions. Question one: how to deal with texts? Texts are something that is unconscious. To fix any unconscious thing, you have to make it conscious. So you have to focus on the tech. My tech, for example, is moving my glasses this way. So I have to focus on it to make it conscious. And once you are concentrating with it, once, twice, and actually repeat this, you will actually stop it. But if you are not paying attention to something that is unconscious, you will do it unconsciously. The second question is, what is the best way to communicate with angry customer? Most of the people who are successful in communication with angry patients, the first thing, you have to be patient. You have to understand his point of view. You have to show empathy. You have to apologize when you are at a fault. You have to accept even some pressure from him. I'm talking here about a limit. And actually you have to start, if he's going to exceed or cross the red line, you have to show some assertiveness. Sir, I'm listening to you. Tell me what I can do, and I am at your hand. So here I'm a little bit showing that my tone of communication is a little bit non-friendly, because you did cross the line. But once he's angry, but he did not cross the line, you have to have a very positive facial expressions. You have to be, you have to talk in a friendly yet assertive way. I think this is the end of my presentation. I have actually some other slides, but actually we can do it next time. I hope it was a beneficial and valuable presentation for all you. You have to talk about communication. I need to end with a very nice quote. It says that success is a journey, not a destination. So you have to continue learning and improving your skills in order to be a successful person. Thank you so much.
Thank you. Thank you, Dr. Rafat, for the very interactive presentation. You can't imagine the interaction on the chat, and thank you all the attendees for this spirit and the interaction. That's the point of these sessions, to network, of course, and to learn more about patient communication and other topics that can be beneficial for pharmacists in KBQ. Now, last but not least, let's welcome our third and last speaker for today, Dr. Iman Al-Sayegh. Dr. Iman is a consultant in obstetrics and gynecology at Royal Hayat Hospital in Kuwait with a subspecialty in maternal fetal medicine. She completed her bachelor degrees of medicine and surgery in the University of Aberdeen in Scotland before she joined the obstetrics and gynecology residency program at McGill University in Canada. She then followed her passion and pursued a fellowship in maternal fetal medicine at one of the largest centers in North America. So again, welcome, Dr. Iman, to the workshop, and the floor is yours. Dr. Iman, you're just muted. If you can unmute your, yeah.
Do you guys hear me?
Yes, yes, we can now.
Perfect.
Thank you.
Okay. So I know everyone has been getting lots of education today, and some of the brain cells are probably tired and sleepy. This topic, contraception, still till this day, I've been presenting about this topic for the solid past 5 years. And I still find that although the information hasn't changed much, however, still putting it all together and delivering it to you without overwhelming you is still a challenge. So I will just start to talk about, I just have to adjust things here. Okay, so when I talk about contraception, or when we hear the word contraception, it just means not getting pregnant, but behind it, there are many layers. Contraception also means saving lives. For example, in women who should not get pregnant because of certain medical condition, it prevents unplanned pregnancies in people who are not ready, whether it is physically, socially, mentally. It improves outcomes for children so that we have children when we are ready to take care of them, when we are physically, mentally, socially, financially ready. Reduces the number of unwanted pregnancies, hence abortions, and also many of the contraceptive methods available also have non-contraceptive benefits. Now, when I discuss contraception with my patients, I usually do it at the postpartum visit, their first visit, after I check their wound, after I ask about their lochia and breastfeeding and all that. I have to remind them about contraception, even if they don't ask. And I usually say, do you have any questions about contraception? Have you ever used any? Would you like me to discuss everything? Because sometimes I feel patients have used certain things and they already know what they want to use, so they don't want to hear the full menu. But for those who know nothing about contraception, haven't used contraception, or I feel still have question marks, I say, okay, you know what? So let's start with the menu. Because they sometimes say, okay, so what's the best thing? I say, that's not really an appropriate question, because there is no appropriate answer. It actually depends on so many clinical characteristics about you, your health, the kind of person you are. I would need to know what fits you. You also need to have a shared decision with me on what suits you. So the menu is as follows, and I usually have this as a cardboard that I picked up from one of the conferences. Not exactly like this, but a similar one, saying, okay, so these are the categories. The first category at the top is what's most effective, meaning the failure is very low. And this is things like sterilization and long-acting reversible contraceptives like intrauterine contraceptive devices. And then the middle category is things with a bit more rate of failure, however, very effective still, and it's hormones, and it can be in pills, it can be in patch. Obviously, there are other types, but the common ones are pills or patches. And then the least effective, however, when we say least, usually we're quoting 13 pregnancies, some quote up to 20 pregnancies per 100 women, things like condoms, counting your ovulation days, and withdrawal. Okay, so these are the categories. I say, okay, we can also present them in two categories. We can say you have the hormonal menu or non-hormonal menu, because sometimes it's clearly strict to, she doesn't want any hormones. Hormones are not in the picture. She doesn't want them, she hates them, she's scared. From her clinical history, you might want to avoid hormones completely. So let's go directly to non-hormonal. So the hormonal category and non-hormonal category are as follows. Hormonal is things like IUDs, the levonorgestrel, the progesterone IUD, or the hormonal implant, or the pill, or the patch, or the ring, okay? Now, some of the things I'm going to be mentioning, they are not available in Kuwait or not very commonly used, but I'm just giving you an overview. Then when we talk about non-hormonal, then we're dividing into copper IUD, sterilization, things like condoms, withdrawal, counting your ovulation, and then obviously spermicide diaphragm sponge, which we don't use often, but they're listed as part of this category. Now, our agenda today, or my agenda today, is to talk about these and kind of delve into them. And as I talk about the different types, hopefully I'll be clarifying misunderstandings, debusting some myths, okay? And clarifying some things about them. So first is sterilization, and that's permanent contraception. Then you have long-acting reversible contraception, and that's copper and the levonorgestrel. Then you have the hormonal contraception, which can be also divided into progesterone only or combined estrogen and progesterone. And then obviously emergency contraception we'll be talking about, because that's very important. And I think as pharmacists, that's one of the important roles you play, because emergency means they haven't had time to see a physician and they come to you in the middle of the night asking you about contraception. So sterilization, we have male vasectomy or female tubal ligation. So for vasectomy, the technique is basically interrupting, occluding the tubes in the males that are called vas deferens, and it can be done under local anesthesia, and the efficacy is usually quoted as more than 99% after, of course, confirming azospermia, which means 0 sperms in the seminal fluid. The failure rate is about 0.15 due to recanalization of that tube that was disrupted. The male needs to use an alternate method of contraception, or the female needs to use an alternate method until the semen analysis has been confirmed to have 0 sperms. Since sperms are stored along the entire tube of the vas deferens and in the seminal vesicles, interruption of the vas deferens doesn't result in immediate sterility, and several ejaculations are actually required to evacuate all the sperms. So the American Urological Association quotes, stop using other contraception when, only when, examination of one well-mixed, uncentrifuged, fresh post-vasectomy semen specimen shows azospermia or only rare non-motile sperm. Only then they can use nothing. Okay, and it means the vasectomy has worked. no other contraception is needed. Now, vasectomy reversal involves reanastomosis of the vas deferens. Success has been quoted 50 to 70%, and the rates decline with increasing time between the vasectomy and the reversal. But I always tell my patients this, and I'm sure urologists tell their patients this, is once you choose sterilization, you're choosing something that is technically non-reversible. If you wanted something that you can reverse later, you might as well not choose sterilization. So the same applies for women. I tell them the same thing when they want tubal ligation. So also compared with tubal ligation, vasectomy is safer, less costly, and has significantly shorter post-procedure recovery time. Complications can be hematoma, infections, sperm granuloma. Chronic scrotal pain has been quoted between 1 to 2%, and as we said, recanalization and failure is 0.15%. Misconception about prostate cancer, cardiovascular risk, definitely misconceptions. They do not cause either. So tubal ligation, it has always been called tubal ligation, but actually it's more than just ligation. So initially, or historically, it was called ligation because they would just disrupt the tube, either through a laparotomy, which is an open incision, a mini laparotomy, or laparoscopically, where they occlude the tube, or then they moved on to doing like a partial salpingectomy. Then eventually now we do complete salpingectomies, because now we know that the origin of ovarian cancer is the fallopian tube. So if someone wants a sterilization, the female partner, we might as well remove the tube, 2-in-1 basically, as contraception and prevention of ovarian cancer. Failure rate is about 1%, which is comparable to the failure rate of either vasectomy or the long-acting reversible contraceptions like the IUCDs. Now, as I said, complete salpingectomy reduces risk of ovarian, tubal, and peritoneal cancers. And the risks are bleeding, infection, injury to intestines or bladder, because remember, you're working next to other organs. The tubes are obviously attached to the uterus, and the uterus has the bladder in front of it and the intestines behind it. Again, what misconception is there is that people are worried it might affect their menstrual function, ovarian reserve, sexual function, or breast cancer. It does not affect any of those. Now that I've completed our section about permanent contraception, let's move to intrauterine devices, which are called long-acting but reversible contraception. So we have the copper IUCD, or we have the hormonal, which is the levonorgestrel, which is the progestin type IUCD. So copper IUCD, 99% efficacy, no hormones involved, long-acting, immediately effective, rapidly reversible, just need to remove it. Few medical contraindications for most women, including teens and nulliparous women. So it can be used in those, because I have lots of misconceptions where people think it cannot be used in someone who's not birthed a child or has not had kids. Few systemic side effects, private, does not interfere with the spontaneity of sex, does not require regular adherence from users to maintain high effectiveness, and reduced cost with long-term use, reduced risk of cervical cancer. Now, they put maybe because obviously there is no biological reason for it to reduce cancer risk. The thought behind it is that these women get it inserted, and usually when we insert IUCDs, we have to put a speculum, so we visualize the cervix, and that also allows you to visualize the cervix for any abnormalities, but also to discuss with the patient the chance of doing her pap test, her cervical screening. And then when she comes for further checks, because IUCDs generally have to be checked after a month, then 6 months, then yearly, that also gives opportunity for, again, looking at the cervix and doing pap tests in those women. Hence why the theory that in the literature they say there may be a reduction in cervical cancer, not because the copper has a magic to reduce cervical cancer. Let's go back. Sorry, I moved too fast. Okay, so copper IUDs, we have the Paragard, the Nova-T, the Flexi-T. Depends where you are in the world, depends what you have in the pharmacy, maybe it also depends on what's easier for you to use. So the Flex CT is what I find mostly available in Kuwait nowadays. And it can stay effective up to 10 years in general, the copper IUD. Not all of them, it depends on the type. Contraindications are Wilson's disease, copper allergy, obviously pregnancy and pelvic infections. And allergy to copper is it's a rare thing, okay? So you have here the picture of Flex CT, and it's meant to be easier because there are no other equipments. This is here next to it, there is in this inserter here, this is the Nova T. I've used both. Honestly, sometimes in certain people, when you have opened the Flex CT and you try to insert it, it's hell because it's hard and it's not easy. And that's another thing about IUCDs, is that in some patients with multiple C-sections or operations, or it depends on their uterine position, it can be difficult to insert an IUCD. And so because the Flex CT, as its name suggests, very flexible, and it's just one instrument, it can be difficult. And sometimes I wish I opted for a Nova T, but it depends. Then you have the levonorgestrel IUCD, which is a progesterone IUCD. There are so many names, so many brands. What we have in Kuwait is a Mirena, which is approved for 8 years. We usually tell patients 5 years, but the FDA has approved it for 8 years. The progestin effect of hormone-releasing IUD is primarily at the level of the endometrium. So this is a very local effect. And obviously the IUCD that releases progestin has also been used for non-contraceptive benefits, like women with early changes in their uterus, suggesting endometrial hyperplasia that may then change to cancer. We use it for those women. We use it also for women who they bleed a lot and we want them to have amenorrhea. Again, it causes shedding and thinning of the endometrium. So these are the non-contraceptive benefits of it. Okay, so it works locally on the endometrium. Now, so copper and levonorgestrel are associated with alterations in bleeding patterns. In general, copper IUDs are associated with heavier bleeding, while the levonorgestrel cause lighter bleeding. So that's another factor here when women say, okay, so we've decided IUCD. Now then she asked me, so which would you prefer? Which would you choose for yourself or for your daughter? Again, I go back to, actually, it depends on you, because if you've had heavy periods, problematic periods, long periods, maybe copper is not for you. If you're someone who really wants regularity, as in you want a period, especially in our community, because when I was in Canada, people did not care about having a period. It was actually very convenient not to have a period. So Mirena was a very popular thing. However, in our part of the world, having menses regularly is important psychologically for different reasons. So I tell them, well, levonorgestrel may be a newer device and has very good non-contraceptive benefits. However, are you okay with not getting menses maybe after 6 months for the next 5 years, or maybe getting minimal spotting here and there, so irregularity? If you're not okay with that, then no, you're just gonna pay for the IUCD. We're gonna have the uncomfort of inserting it. Then you're gonna complain that you don't want it. Now, there are ways for us to reduce the spotting that can happen, but it may not work with everyone, and you have to wait for your body to get used to it. Risks of pelvic inflammatory disease. So a lot of people have the misconception that there is higher chance of having infections or sexually transmitted infections with the IUCD, and that's not true. The risk is slightly greater with the IUD only if there is an actual untreated sexually transmitted infection during insertion. So one of the things that we also do as a standard is obviously when you take a history and when you discuss with patients and decide that you want to insert it, you have decided this based on the information that this patient is not at risk of an STI currently. But I also tell all my patients, I'm going to do a vaginal swab when I insert. It's going to come back in 3 days so that if you do have an infection, I will call you with a prescription of antibiotics. So that if you do have one, then we're not pushing it up into the uterus and stays there and creates a pelvic inflammatory condition. Risk of ectopic pregnancy is higher only if pregnancy occurs. Now, you're actually putting a contraceptive, so pregnancy rate is lower, right? But if it does fail and a pregnancy does happen, then because the uterus is now an environment that does not accept a pregnancy, yes, it will increase the rate of ectopic. However, it doesn't mean that putting an IUCD increases the rates of ectopic pregnancies, if you see what I mean. The incidence of expulsion, as in falling in the first year, is about 2 to 10%. I tell patients you have to come and check in 1 month, 6 months, and yearly. If you suddenly lose more than 5 kilos in a few months, come and check it. If you're worried for any reason, if your partner feels the thread, it might not even have fully like expulsion, but it has moved to the lower uterine segment or it's sitting in the cervix. Both can be, like the levonorgestrel and copper, inserted as emergency contraception within 5 days from unprotected intercourse and has the lowest pregnancy rates. Okay, and we'll talk about emergency contraception. So now I've completed the second category, which is the intrauterine contraceptive device. And as we said, we have 2 types, copper and the levonorgestrel or progesterone. Now let's move to hormonal contraception, and that is divided into combined estrogen progestin or progestin only. So the combined estrogen progestin contraceptive can come in a pill form, in a patch, or as a ring, have a similar contraceptive mechanism there, all of the above, as in pills, patches, and rings. So it inhibits the mid-cycle surge of gonadotropin secretion so that ovulation does not occur. It suppresses gonadotropin secretion during the follicular phase of the cycle and hence prevents follicular maturation. So during our menstrual cycle, basically we have hormonal regulation that is allowing a follicle to mature to then release an egg. So these hormones are inhibiting the gonadotropins that allow this maturation and ovulation. The progestin-only contraceptive, however, works on the cervical mucus by thickening it, works on the fallopian tube motility, makes it harder for the egg that is trying to move through the fallopian or the embryo through the fallopian tube and for the sperm for them to meet. And the endometrial receptivity that also makes it unfavorable for fertilization and implantation. So the progestin only, let's start with that. So the contraceptive mechanism, again, as we have already talked about, the mucus of the cervix, the fallopian tube motility, and unfavorable for fertilization implantation. Progestin only is, one of them is the levonorgestrel, but we've talked about because I've categorized that in the section of IUDs. We're now going to talk about the etonorgestrel implant, the depo-medroxyprogesterone acetate, which is Depo-Provera, and pills. The advantages, obviously no estrogen, reversible, and no surgery required, okay? Disadvantages, unscheduled or breakthrough bleeding, which I talked about earlier when choosing Mirena or levonorgestrel rather than copper. What about contraindications? So known or suspected pregnancy, hepatic tumor or active liver disease, undiagnosed abnormal genital bleeding, known or suspected breast cancer, history of breast cancer or other progestin-sensitive cancers. So these kind of cancers are one of the main cancers we worry about when we talk about progestins. So let's move to the etonorgestrel implants. So data show no decrease in contraceptive efficacy, even though etonorgestrel concentration is affected by weight, and use postpartum and during lactation. No delays required. Benefits are believed to outweigh the risks. So these are the two main important points I want to say about this, okay? So simply, it looks like this. It's the size of a matchstick. It comes in an applicator. It's inserted under the skin. Non-dominant side, non-dominant arm. Right here. Here again. A patient would have it inserted under local anesthesia. And again, removed under local anesthesia whenever she wants. Again, she has to bear in mind the irregular bleeding that we talked about, and that she will have it removed, and that obviously if there is huge weight gain, and especially fat tissue, it may get more difficult to remove because fat tissue develops on it. But otherwise, it's a very effective form, has gained popularity in Kuwait. But again, a lot of women cannot withstand the irregular bleeding or not having periods, and some are loving it. This is what the applicator looks like here. The etonorgestrel implant, the rod contains about 68 milligrams of progestin. It's released slowly, the etonorgestrel, the actual component, initially 60 to 70 micrograms per day, and then it decreases to 35 to 45 micrograms per day at the end of the first year, to 30 to 40 micrograms at the end of the second year, and then 25 to 30 micrograms at the end of the third year and beyond, hence why they have to remove it after 3 years. And the examples are Implanon, Nexplanon. In Kuwait, we use Implanon. Most women are candidates. Very few have medical disorders where the risk of the method exceeds benefit. And again, it's breast cancer and liver disease, active liver disease. Medroxyprogesterone acetate. So this is not really an injection that I use. There are sometimes when I started presenting about contraception that I thought it wouldn't be necessary to actually talk about it because we're not really using it. However, the reason I still talk about it, I'll tell you why. So first of all, as I said, it's called Depo-Provera. It's a progestin only, it's injectable, it's effective for 3 months. And the candidates are those who desire highly effective reversible method that does not require daily use. But then you also have IUCDs and you have the implant. Want to avoid an estrogen-containing method, want to eliminate menstrual bleeding, want non-contraceptive benefits such as reduction in dysmenorrhea and pelvic pain from endometriosis, prefer private, discreet method of contraception, not compliant with methods that require frequent or pericoital administration, difficulty using other forms of contraception. Well, everything that I've just said, you can use IUCD for, Mirena, or you can use the implant that I just talked about. However, it's the last point that always hits home about the importance of the existence of DMPA. Physical or intellectual issues that make other methods difficult to use or remember. It would be very hard to put an IUCD in someone with the physical or intellectual issues, or many different issues where someone cannot sit or lie on the bed with their legs open, where you're able to insert a speculum. This comes really handy in those situations. And then also putting an implant, it might seem like a simple procedure to us, but it does cause anxiety to patients that you're going to put something in their hand, they get an injection of local anesthesia, then they have to sit still, you have to apply the applicator. This is an injection, intramuscular, gets done, and it's much easier in this certain category of patients. Now, the issues that come in mind when we talk about DMPA is return of fertility, which may be delayed, okay? Within 10 months of the last injection, 50% of women who discontinue DMPA to become pregnant will conceive. However, in a small proportion of women, fertility is not reestablished until 18 months after the last injection. Before initiating, clinicians should counsel candidates about the possible prolonged duration of contraceptive action. Women who may want to become pregnant within the next 1 or 2 years should choose an alternative contraceptive. So this is one issue that has been raised by the community. And yes, it does exist, but you now understand that it's not forever. It's just a little bit more delayed. The other issues that exist have been refuted. So ACOG, CDC, Society of Adolescent Health and Medicine, World Health Organization, SOGC, believe that the advantages of DMPA use as a contraceptive generally outweigh the theoretical concern regarding skeletal harm, because that was also another thing that was raised by the community, is skeletal harm and osteoporosis. Skeletal health concerns should not restrict initiation or continuation of DMPA in adolescents, patients 18 to 45 of age, or older reproductive age individuals. The available evidence also does not justify limiting the duration of DMPA therapy, which may be safely continued for decades. So I just bring these points up because they are raised by the community. However, as I said, this is not a common type of contraception that we use. So I will move from implants to the injection and now to the pill for progestin only. So for progestin only, POPs are one option for individuals who cannot or prefer not to use estrogen-containing contraception. The type of progestins in the oral pill containing only progestin is northistrone and levonorgestrel, drospirenone, and desogestrel. Now, again, I am listing many types, but I will be talking always about what we are currently using. So for example, what I am currently using in Kuwait is Cerazette, which has desogestrel. It's a common one mainly for breastfeeding women, okay, because we know that combined estrogen progestin can reduce their milk supply. So especially for the first 6 months, where a baby completely depends on the mother's milk supply and she doesn't want anything that affects her milk supply, then Cerazette is the way to go. So it gets taken daily. So for Cerazette, daily, and generally the recommendations for how long you can postpone the tablet depends on the type of progestin. So with desogestrel, 12 hours, drospirenone within 24 hours. With northindrone and levonorgestrel, you need to take it within 3 hours of the same time each day. So you can't delay that much. Again, thickens the mucus of the cervix and also prevents ovulation, as all other progestins. Side effects, again, as in all other progestins, unscheduled bleeding and changes in the menses, even amenorrhea. Increased prevalence of follicular ovarian cysts have been documented in the literature, and acne flares also have been reported because, as you know, some progestins can have androgenic activity. Again, this was now with the world using ChatGPT. I just wanted to show you how, and I tell that to all my colleagues and myself, that it's now very easy to get information. And so when a patient comes to the pharmacy in the middle of the night, and you feel, you're not sure about the information or about the medication itself, other than obviously the pamphlet that's with the medication, if you just put Cerazette on ChatGPT, it gives you great, concise summary. So it's a desogestrel, it's estrogen-free, it suppresses ovulation, 1 pill daily can cause irregular, lighter, or absent bleeding. And it's good for those who have contraindications to estrogen, like clot risks or smokers over age of 35. And it's good for those who are breastfeeding. Okay. So I was happy with the summary it gave as I'm playing around with it. Because I know a lot of patients feel that, like even when they see my colleagues in other specialties, and they tell them, oh, I'm not sure if I can give you this antibiotic while you're pregnant. I'm like, just use ChatGPT rather than the patient having to wait weeks to see me and she's not really using the medication because she's worried, or she's using it, but she's been anxious, or she's messaging me in the middle of the night. You know, you're in the office, you could check nowadays and get all the info you want. Progestin only oral pills, probably this is a repeat of some of the info, so should be initiated on the first day of menses. That's how we start them. That's one way, but then and that in that way you don't need backup contraception because you're starting them on the first day of menses. They have their period for the next 7 days, and if it started within the first 5 days of the menses. Some conditions initiate POP at any time, because that's another misconception that we have to start contraception at the first day of a period. That's not necessary. That was historically advised so that women don't have to use a backup method. And also you're sure they're not pregnant, okay? So some clinicians initiate POP at any time in the cycle as long as they are reasonably certain that the patient is not pregnant. Backup contraception is needed for 7 days if the patient is more than 5 days from the onset of menses, or if you're using northistrone dose is late more than 3 hours or it's missed because the efficacy goes away for that specific type of progestin. Progestin-only pills can be discontinued at any time the patient desires. Upon discontinuation, fertility returns rapidly. And honestly, that goes for any kind of combined or progestin-only pill or IUD. You can discontinue anything you want there and then. No such thing as graded, like we're not using cortisones here. You don't have to taper off. Routine follow-up is not necessary. Women can come as needed. You don't need to follow them up like intrauterine contraceptive devices, for example. So we have now also completed the progestin-only pill part of this topic. Now I'm going to move to the combined hormonal contraception. So now we're talking about things that have progestin, but also estrogen. And again, they come in different forms. So we have the oral pills, we have the patches, we have the vaginal ring. Again, I am giving you all the options, but here in Kuwait, we have the pills and the patches. We do not use the vaginal rings. Now, when we talk about combined hormonal contraceptives, let's go with the main concerns that people talk about. So weight gain. So no, 49 meta-analyses were done. There are no substantial differences. So I tell again women who tell me, so what's the best type to use out of what's available in the pharmacy? I say again, there is no one best type. Most of the ones we have nowadays are great because they have reduced the amount of ethinyl estradiol in them, and we'll talk about that in the next few slides. It's the progestin that's an issue, and different women have different responses to progestins. Yes, some progestins may be more, cause maybe a little bit more water retention or maybe more androgenic activity. However, women respond differently. So there is no one best type, and no, it does not increase weight gain. However, if you have used it and you did feel that it increased your appetite or it did cause water retention, then maybe that's not the best one for you. Mood disturbance, combined oral contraceptives with 35 micrograms or less of ethinyl estradiol appear to have minimal effect on mood. symptoms, unlike the older, higher estrogen formulations that had 50 or more, although all formulations have not really been evaluated. Potential confounding variables that impact studies of the combined on mood include retrospective data, observational design, presence of underlying mood disorders, phase of treatment cycle, presence of other socioeconomic factors associated with mood disorders, absence of patient's counseling. So again, I tell patients, your sister might have felt this, your cousin might have felt this, you may not. You want to go ahead and try it, or try what they've loved. If it worked for them, it may then work for you, even just as a placebo effect, because you've heard that this X brand is amazing. Go ahead and use it. If you don't like it, then we can explore other ones. And I always say, please use something for about 3 months before you decide you hate it, unless whatever side effect you're getting is very unacceptable, then we can change sooner. But your body does need to get used to it. While the available prospective data are conflicting, most studies suggest that combined contraceptives, hormonal contraceptive use has no negative impact on mood for most women. Libido, no significant impact on sexual function. Mixed results have been reported. Again, mood comes into play. If you're moody, if you're angry, if you feel that it's causing you weight gain or water retention, you're probably going to have low libido. Return of fertility, so the use may slightly delay time to conception. However, this effect is limited to the first several months after COC discontinuation. So it's not really something that we would tell women, like when we talk about the MPA, that there is a delay. That's not necessarily true, because I tell women sometimes even just not taking your tablet on time while taking OCPs, you can actually get pregnant. So no, they do not delay fertility. What about benefits? So what non-contraceptive benefits, again, that we talk about now that we've addressed the concerns? What are the benefits that usually we hear about with OCPs? So yes, they can affect ovarian cysts. They can eliminate the risk of developing functional cysts, which can cause pain and may result in ovarian torsion if they get too big, obviously. Usually more than 5 centimeters, that's when we worry and need to have them removed, but you can get ovarian torsion with smaller ones. Menstrual bleeding and cramps treats, the benefit is that yes, they do treat the menstrual bleeding that's heavy and the cramps, and also the dysmenorrhea that some women have. And the cyclic use increases menstrual regularity, while the continuous combined hormonal contraceptive use results in menstrual suppression. That's another thing I'm going to be coming to, that actually some women use it continuously, the OCPs, without a pill-free period or without a menses break, because of whatever condition they have, so that they do not get their period, so that they eliminate the heavy bleeding or the dysmenorrhea. So they're actually using the OCPs as part of a treatment regimen. And then for acne and hirsutism, reduce free androgen concentration and improves acne and hirsutism. So again, some people may say, well, it caused me acne, it caused me this. Again, it depends on the progestin, because actually for some, we use it and it actually helps their acne and hirsutism. What about contraindications, things that we should not be using combined hormonal contraceptions for? So based on the CDC and the WHO medical eligibility criteria, age more than 35, smokers, multiple risk for arterial disease, hypertension, VTE, known ischemic heart disease, history of stroke, complicated valvular disease, breast cancer, severe cirrhosis, hepatocellular adenoma, migraine, diabetes. And the reason, later I'm going to show you that actually now they've developed amazing applications, the medical eligibility criteria applications. They even give out pamphlets and wheels for you to very easily take a good history, use that history to see what your patient has, medical conditions, and then decide, are they eligible or not. So the types of combined hormonal contraceptives, now that I've talked about the benefits and concerns and contraindications, first is the pills, and they're reliable. They have non-contraceptive benefits. They contain estrogen, and as I said, a bunch of dozen different progestins. And really, I think the estrogen is ethinyl estradiol in each and every one of them most of the time, not all the time. It's just the progestin that changes. Low dose formulations are now available. They're less than 50 microgram of ethinyl estradiol. They're safe and reliable options for the vast majority of women. And combined oral pills, as I said, for healthy non-smoking women may be continued until the age of menopause. All combined oral contraceptives are effective and have similar advantage and disadvantage. Factors to take into consideration when selecting the combined oral contraceptives include patient's past experience, as I said, patient's preference, the clinical characteristics, insurance coverage and cost, relative safety considerations, side effects and relative risks may vary based on the estrogen dose and the progestin type and dose. Shared decision-making that takes into account patient preference will improve adherence to any contraceptive method. Therefore, if a patient requests a particular pill, it is reasonable to prescribe it. As I said, if a patient already has a preconception that something is not going to work for her, something is not going to work, or something that might harm her, or her cousin hated it, or her sister, go for the other thing. Don't use that same thing, because she's not going to like it. She already has a misconception. And then examples of combined pills. So this isn't from UpToDate. This is just to show you that there are so many different types. There are types that I've used when I was in Canada or when I was in Scotland, some that here. This is, for example, from UpToDate. Just so if you look here, ethinyl estradiol, estradiol valerate, ethinyl estradiol, the progestins, drospirenone, Dionogest, levonorgestrel, different. So basically combined hormonal contraceptives is just the brands have different types of estrogen and progestin. And the progestin, when we say different progestins, because that's the main issue, it just depends on generation of when they were created, the progestins. So we have first generation, second generation, third. I've just created my own little summary. These are the most common that are used in Kuwait, just to give you an example here. So for example, Yasmin 21, ethinyl estradiol, and drospirenone 3 milligrams, no placebo pills. That's another thing when you're looking at the different types. So not only estrogen and progesterone are different, and so the side effect profile may be different, but also then you have things where there are placebo pills or no placebo pills. I tell patients that read your pamphlet. There are some extra pills that are sugar pills, they're placebo pills. You don't need, so you can take them if you want. They put them there, the manufacturers put them there so that you're taking a tablet every day so that you don't forget. But it's not crucial, because then, some people messaging you, oh my God, I forgot to take that tablet. So I think when a patient understands it's medication, it's very important. Then there's the Yasmin 28, where there are placebo pills for 7 days. There's a Drospera, which is 24. Yes, 4 days of placebo. Yaz, 4 days of placebo. And here the ethinyl estradiol is less. Genera, the same ethinyl estradiol, however, a different progestin, no placebo pill. Marvelone, the same ethinyl estradiol, different progestin, no placebo. Gracial 22. So that's a multiphasic one, and we're going to get to that, where the estrogen comes in the first 7 days at 0.04 with the desogestrel of 0.025. Then the next 15 days, it's 0.125 desogestrel, and there's no placebo. So this is, again, courtesy of ChatGPT. If you just compare, if you just tell, okay, so compare types for me, gives you Gracial that I just talked about, the one that is multiphasic, and it tells you it's 22 pills, 7 blue, 15 white, 7-day break, no placebo, okay? Marvelone, 21 active pills, same pills because it's a monophasic, and then 7-day break. Yasmin, 21 active pills, again, monophasic, same color pill, 7-day break. If you use the Yasmin 28, you will have placebo, 7 days. Beautiful, small little table that can be generated. And then again, look how it talks about the progestin, anti-androgenic effect, Gracial mild, Marvelone mild, Yasmin stronger because of the type of progestin. Water retention, here is slight for Gracial, slight for Marvelone, reduced due to the drospirenone and Yasmin, okay? And then if you want non-contraceptive benefit, well, Gracial is standard contraception, Marvelone standard contraception, but then Yasmin has also reduction a little bit of her acne and PMS and PCOS. So all the info is out there. And again, I just have decided to show you guys pictures of all these that are available here in Kuwait. And it just makes it easier for us to realize, oh, these are available at the pharmacies. And you know what? There's no magic specifically about one of them. And mostly it's all ethinyl estradiol. It's the progestin that changes. And some have placebo, some not. Most of them are monophasic. Only Gracial that I know of in Kuwait that is multiphasic. So as I said, monophasic contains same dose of estrogen and progestin in each active pill. Multiphasic vary the dose of either or both hormones during the active pill phase. Multiphasic were introduced as a strategy to reduce hormone dose and thus hormone-related side effects and unscheduled bleeding, as well as business-related reasons such as patent expiration. Companies also have that issues to deal with, so sometimes they have to do that. There are no data that these preparations have any important clinical advantage. The contraceptive efficacy appears to be similar across all. So monophasic, multiphasic, doesn't really matter. The original intent of the regimen for cyclic use, and here I'm not, so we're done with mono and multi. When I talk about cyclic use, I'm talking about the 21 days, 28 days, 24 days. The original intent of the regimen was to provide a monthly bleed that patients would interpret. So take it for 21 days, take nothing for 7 days, or placebo for 7 days so that you get your period. This was required at the time for pill acceptance and to reassure women that she was not pregnant. Today, with the lower doses of hormones used in oral combined pills, and the knowledge that we have about menses and periods and the understanding, it is recognized that the 7 days of hormones, off the hormones, and getting a period is not really necessary. Okay, hence why when people go to Hajj, for example, they just they can take pills to postpone their menses, or people who are traveling to places where they don't want their menses, it's not convenient, we can just postpone their menses. And obviously in the Western world, they even take that further and postpone menses for months. So general principles: choose generic for affordability if possible, monophasic as the initial prescription due to ease of use and consistent hormone dose, which improves adherence. This is a key component for effectiveness, adherence. Multiphasic require more careful adherence to a specific sequential order in which to take the pill each cycle. Furthermore, multiphasic pills cannot be transitioned to continuous or extended cycle use the way that monophasic pills can. Patients should be queried regarding achieving the frequency of withdrawal bleeding they desire. Again, as I say, this is not a huge issue in Kuwait. Everyone wants their monthly period, but some may prefer monthly withdrawal. Others may opt for every 3 months, which means 84/7, or prefer no withdrawal. Ethinyl estradiol in most. Ethinyl estradiol has been reduced. The data regarding safety of 20 versus 25, 30, or 35 suggest less risk with 20, but are not strong enough to endorse using just 20. So anything less than 50 is great. Go ahead and use it. Progestins, as I already said, there are different generations. They were introduced to the market not on structural and physiological differences. In general, third and fourth generation progestin are less androgenic and have fewer side effects than earlier generations. Just to bear that in mind. Again, they do not increase cancer combined oral contraceptive pills. Okay, so that's the summary of this slide. Okay. Now let's move to patches. We finished pills. Now let's go to patches. Everest, what's used in Kuwait. The patch is changed once per week for 3 weeks, 21 days total. Again, a patch-free week. Hopefully now you understand that if she does not want that that patch-free week, she can go ahead and put another patch. To maintain contraceptive efficacy, there should never be more than a 7-day patch-free interval. The patch should always be changed, applied on the same day of the week. Reminder systems are useful to ensure appropriate weekly changes. So if you want not to have a period, not to have a patch-free week, go ahead. But you can't be off the patch for more than 7 days. Combined patch contraindications, again, so VTE, patients with VTE, the same contraindications that apply for all hormonal contraceptions is the same, whether it's pill or patch. However, specifically for patch women with BMI more than 30, not because of just their risk of clots, but also maybe lower efficacy. Neither patch should be used in patients being treated with hepatitis C with combinations containing these types of medications. And there's a small slide about medications and contraceptives, or in patients with hypersensitivity to any component of the transdermal patch. Individuals with a history of sensitive skin or exfoliative dermatological disorder may not be ideal candidates for using transdermal systems, okay? Patch versus pill. Potential benefit of patch, weekly rather than daily, a non-oral route of administration for patients who have difficulty swallowing. Therapeutic effects are achieved at lower peak doses. There is first pass hepatic metabolism and enzymatic regulation in the GI are avoided. Sustained drug delivery. Potential benefits of the oral is that pills are more private than a visible patch. Pills do not detach. Emergency contraception. So provide safe, effective method to prevent pregnancy after unprotected intercourse and sexual assault or contraceptive failure. It's most effective when used as soon as possible. So there is again, small summary, again, just to show you guys that there is pills, there is IUDs. For the pills, you have the levonorgestrel, which is the Mirena. You have ulipristal. The levonorgestrel is like Plan B, which I'll talk about. Ulipristal is also tablets, and then the IOSP method, which is combined oral contraceptives. When it comes to devices, then you have the copper IUD or the levonorgestrel, which is Mirena. Sorry, I'm moving backwards. So this is for emergency contraception. So as I said, these are the oral ones, okay? Ulipristal, levonorgestrel, and the IOSP. Now the IOSP is very interesting because you want to achieve 100 microgram of ethinyl estradiol at once and 0.5 of levonorgestrel and repeat that dose in 12 hours. And sometimes getting the IOSP method means using any type of contraceptive that would equate to this. Sometimes means taking 5 tablets at once. The levonorgestrel is called Norlevo or Plan B. Plan B is what we have available in the pharmacies, and it's 1.5 milligram of progestin. This is the IOSP method, just gives you example of tablets that I have not seen in Kuwait, and it just shows you how they combine them into many tablets to create that mixture. Mifepristone we don't have in Kuwait. They are worried about it as an abortification medication, but also works. Again, important points to realize here. So oral emergency contraception absorption is impacted by obesity and malabsorption. Body weight does not impact efficacy of an IUCD. So you have to take that into account if you want to use pill or IUCD. Emergency contraception methods are safe and well tolerated. However, side effects may vary by the method. So IUCD, tell them about abdominal pain, pelvic pain due to the insertion. Yes, there is risk of perforation, always risk of infection, especially if it's unprotected intercourse. Is there risk of sexually transmitted infection? Both for ulipristal and oral levonorgestrel, they are safe. However, they are safe, and we are not worried when it's an emergency contraception about thrombogenic events like we are with combined oral contraceptives on the long run. Okay, so do not worry about VTEs. If someone needs an emergency contraception, they can take high-dose estrogen. It does not require a doctor visit. However, the OSB method may cause nausea, vomiting, which is more than with the other ones. The use of emergency contraception does not reduce risk of STIs, very important. Emergency contraception does not impact future fertility, and all emergency contraceptive methods are safe for adolescents and lactating individuals. Very quick slide, medications. Yes, certain medications will affect hormonal absorption. Please check what medications they are. Do not just tell women, you can't, you are on an antibiotic. Most antibiotics are safe. Please use ChatGPT, use Google, use whatever, but just don't say you cannot take it. If she doesn't want to get pregnant, please help her not to get pregnant. Mostly it's the CYP450 enzyme system, and it's only certain medications, those for like tuberculosis, like the rifampicin class antibiotics, certain anti-seizures, St. John's wort, griseofulvin, which is an antifungal, and then obviously the new trends with Ozempic and Saxenda, just because it may interfere with absorption of hormonal contraceptives and also may cause GI symptoms, such as nausea, vomiting, delayed emptying, so consider backup. Follow-up after emergency, very quickly. You should get period in 3 weeks. If you don't, please see your doctor or do a pregnancy test. While most do not require a specific follow-up visit, they should seek medical attention if heavy bleeding with abdominal pain, because it may be an ectopic. Just because you gave emergency contraception doesn't mean it worked. You may need a pregnancy test or have concern regarding lack of return of menses or bleeding. Oral emergency contraception will not protect against future pregnancies, so from further intercourse. So just because I gave this to you now doesn't mean you're protected from intercourse tomorrow and after tomorrow. IUCD will likely cause irregular bleeding, so do not be shocked. And women should do a urine pregnancy test 2 to 4 weeks after IUCD placement at any time if pregnancy symptoms persist. It is possible that the pregnancy also existed, like you may have taken this, but you may have taken it after 3 days and the intercourse happened during ovulation and the pregnancy is just there. So emergency contraception use also does not appear to increase ectopic pregnancy if used, and the woman is gonna get pregnant, it will not increase it. Should a pregnancy occur after IUCD placement, the IUCD should be removed. Options and counseling should be provided. Sorry, should not be removed. So if you put an IUCD for someone because they want it as an emergency, you can just leave it. Khalas, that's their contraception for the next 5 years if they want, or whatever years they want. So how does emergency contraception work? Prevents ovulation, disrupts luteal phase, changes the endometrium, lowers hormone levels, changes cervical mucus, and prevents sperm from fertilizing an egg. Okay. Conclusion. So contraception counseling, definitely not a walk in the park for physicians. And although I say you can use ChatGPT, you can use Google, and I say it as if it's easy, it is definitely not always easy, but I'm just saying now with all the resources available, do not leave patients hanging or without info. But yes, it is difficult. There is lots of information, lots of medications, lots of things to take into account during counseling. Till this day, I find it challenging doing the counseling. Equally, it can be challenging for patients to understand and accept and make a choice. Physicians have a responsibility to continue to update themselves about contraception and find effective methods and tools to counsel patients. Pharmacists have a huge role to play in compliance. because patients do ask pharmacists a lot about, do you really think I should use this? Do you think it's good? Do you think it's going to cause cancer? They sometimes forget everything we've discussed in the clinic and then suddenly come to the pharmacist and make it look like there was nothing told in the office. So they troubleshoot with you also, and definitely they come to you for emergency contraception. References up to date. There's the FlexiT website, Mirena website. There is this great medical eligibility criteria for contraception that the CDC has created. There is an app, there's ChatGPT. There's this wheel that I have in my clinic that I love. Basically, you're putting the disease and then you're seeing, is she eligible? Is she number 1? Is she number 2? Is she number 3? What can I give her? Because you can't obviously remember everything about all these medications. And then again, there's this phone app, like I told you. Again, you can put in your patient's characteristics and it can tell you what to do. And then they come also in these like pamphlets. Again, it gives you the patient's condition. It gives you each different type, and it tells you she's 4, she's 2, she's 1, go ahead. If she's 4, please don't go ahead. Red, don't give it. Okay. And I think I'm done. And I think on purpose, I didn't open the light just to show that we've gone from morning till evening as I'm presenting.
Yeah, thank you. Okay. Thank you so much, Dr. Iman, for all your efforts and for the great presentation. You can't imagine the interaction on the chat. All the comments are that this is very informative, amazing, and it was really informative. So thank you very much again, Dr. Iman, for all this information. I have actually like a couple of questions. Maybe I can club them in one. It's all related to the IUDs. So the difference between copper and gold IUDs, and can copper IUD be used for 10 years? The other one is related to the hormonal IUD and its safety with cancer, and can it be used with uterine fibrosis, for the management of uterine fibrosis?
Okay, so I'll answer copper first. Yes, some can be used for 10 years. Okay, there are different ones. As I showed you, there are different types. So I would open the pamphlet and see what the drug manufacturer has told me, the amount of years I can use. Some you can use for 5 years, some you can go up to 10 years. Okay, so that's for copper IUCD. In terms of the Mirena or the levonorgestrel, you can use it for mostly anyone. Okay, because as I said, it works local. The hormone that is in the medication will not go systemic. Okay, and the question was, can it be used for fibrosis? I'm assuming they mean fibroids in the uterus. So yes, if it will stay, yeah, it depends on where your fibroids are. If your fibroids are subserosal outside the uterus, then it will fit in nicely because it sits in the endometrium. However, if you do have an abnormal uterus with an abnormal uterine wall, it may not even be easy to insert it for you. Because remember, and that's why after we insert, we check with an ultrasound transvaginal to make sure it is sitting appropriately. If your uterus is not sitting appropriately in your uterus, it may be inside, but if it's not sitting in the right place, it will not protect from a pregnancy.
Yeah. Thank you again, Dr. Iman, for this great information. And by this, we came to the end of our session today. Thank you all for attending today and for your participation and active participation as well on the chat. Please note that you will be receiving an email after this webinar with a link to a small quiz that you will need to answer in order to receive the end of the session certificate, and for the CME points as well. So please stay tuned for this email. We also will be sharing the recording of the session if you need to repeat it or have any of the lectures repeated again. But again, please, we need you to complete the quiz in order to be eligible for the CME points and for the certificate at the end of the course, of the whole program. Thank you again, and have a lovely evening. Thank you.